So welcome to the meeting. We have a number of observers today, not least we have two of our graduate trainees whom we're really happy to welcome here, and I do hope they will find the meeting interesting and informative, but we will be seeing quite a lot of our graduate trainees who are really important to the future of the way in which we can deliver care, so welcome to you. As we all know, the systems are under the most inordinate amount of pressure at the moment. The staff are doing an unbelievably good job to maintain patient care and the quality of patient care, but we know that there is huge strain within the communities and within our hospital services and the primary care. We are striving still to provide a high quality of appropriate care to people, and our staff have really gone above and beyond, and we will be coming back to this in the next part of our meeting. The executives are working extraordinarily hard to improve the situation and working hard with partners to find cogent solutions to some of the problems that we as a system are facing. And I do commend them for the work that they have been undertaking diligently and at pace. We have a number of apologies for absence. We have Helen, who's on annual leave, Pippa, who is also on annual leave, and Phil Robson. He may join us slightly later. We've got a number of welcomes. We have Sarah Simmons attending for the first time as our newly appointed Human Resources Director, and we have a very sad goodbye, hopefully temporarily goodbye, in that Emrys has had the honour to be appointed as the interim chair of Cwmtaf Morgannwg Health Board. He will take up that position on the 1st of October. I personally am really, really sad to see him go, as he's a magnificent colleague, I have to say, but I don't think anybody better could have been asked by the minister to take over that daunting responsibility. And I know that he is already desperate to come back to us, and he hasn't started yet. But you know, we will keep in very, very close contact, both through chairs meetings and through personal updates. But we wish him every success, and if there's any help we can provide to him and his teams, you know where we are, Emrys, and thank you for everything that you have done so far. But you haven't gone yet, so I've got a nice long list of things you've got to complete before you disappear. I'd like to welcome Angela, not Angela, goodness me, the CHC, Gemma, and James Quantz from Internal Audit. I don't know, Richard, if anybody else is not here or is due to attend or what?
We have obviously apologies from Leanne Watkins, and we don't have any Audit Wales attending today.
Right, fine. Thank you very much. Thank you. Are there any declarations of interest to be expressed on any issue on this agenda? No? Can we then move to approval of the draft minutes of the Health Board on the 28th of July? Are there any amendments to these minutes? If not, I will accept them as a true record and go on to the action log. Richard.
As Chair, the action log within the minutes has been updated, and there are no outstanding actions.
Okay. Has anybody any issues that they would wish to raise that are not in that action log from our last meeting? No, thank you. On to 1.6, report on sealed documents and chairs actions. Richard.
Again, yes, these are included within the documentation. Excuse me while I find my sheet of paper, which I just had in front of me. There are 3 sets of sealed documents and one chair's action. By approving the sealed documents, we are complying with our standing orders.
Okay, any comments or queries? No, thank you. My report, very short this time, although it seems to have been tremendously busy. You may or may not know that the Minister with her colleagues is holding sort of weekly, sometimes fortnightly, but very, very regular meetings now between the system and Judith and I and Carol Shillabere represent the health service. We have 2 leaders and a director of social services, ADSS and the WLGA, to discuss system pressures. She is very action focused. There is a meeting today, but of course Judith and I cannot attend as we're at the board meeting. So we will receive feedback from Carol Shillabere, but there is no doubt in anybody's mind about the pressure within the system at the present time, and the Minister's impatience that practical, concrete improvements will be made. And this is reflected in some of the issues which she has been talking to chairs about recently. She is very clear about the way in which she wishes to hold health boards in particular to account. Chairs have been asked after our meeting with her last week to provide her with a list of the priorities that we think as health boards we need to pursue over the next year, 18 months. So we are providing information to her from our annual plans to inform her decision making on those priorities. There will be 10 major ones with some nuances for health boards depending on circumstances and challenges. But she is very intent on the system working in a more effective way and in keeping on the pressure, quite rightly, for us to improve the situation, difficult though it is. So the other things that were discussed at the Ministers' meeting last week were the ability of health boards in particular to become an effective partner in the foundation economy, which we have signed up to. Longer term type of priority and objective, but nevertheless, we have made a very good headway already in terms of our joint apprenticeships with industry and with local government, and in the way in which we have reached out to communities for employment opportunities. So she's pleased to see us taking the first steps, but will be asking us definitely what we're going to do next to improve the situation. She is also very interested in the development of our community and primary care services and how we are changing our care pathways so that more care is provided within community settings to avoid people being on secondary care waiting lists. So we are providing her with information on that. So these are very intense meetings, as you can imagine, but there is a very clear agenda emerging, and we will have our priorities as a health board to which she will hold us to account within the next 3 weeks. But it was, I think, extremely helpful to be able to be given the opportunity to contribute to her thinking on those issues. I've been to 2 chairs meetings where we have discussed the current COVID situation, including the public health far-reaching assessment of COVID over the next year. We have also discussed social care and what we are all doing, working with our system partners and what schemes we are putting together to try and ease the tension within the system and the pressure for individuals. We discussed governance in health boards following the Audit Wales report and are sharing a work programme with our board secretaries on what we should be taking forward in terms of the improved management of boards and their governance over the next year. We have had a meeting with the Children's Commissioner, which was really helpful, always challenging, but always very supportive, and recognised the very good work that was going on within health boards to improve access to the right types of services for children without being pushed from pillar to post. So she's very pleased to see what has happened and will be following through before she leaves her position next year. We've also had a presentation from the Wellbeing of Future Generations Act Commissioner about her expectations, which I will circulate once she's signed them off. And finally, we have discussed the National Clinical Plan, which will come to the board next time, and how we devise our plan to accord with the principles within that National Clinical Plan and its framework over the next 5 years. So that has been what's discussed in chairs meetings. I've also continued my meetings with local authority leaders, which I find very supportive and helpful, and I hope they do too. A lot of it is absorbed by COVID and the consequences for the system. But nevertheless, I think we all find them a very useful forum in which to share challenges and information. I've attended 2 regional partnership board meetings at which the future work plans are being discussed together with the future funding streams that are becoming available from the government. What we now have to decide is which schemes we have funded are really successful and should be continued, and how they will be monitored, and those that have not met the objectives and what we will do about them. So that's at the next meeting, we'll have to discuss that. And I've continued to chair the vascular steering group to develop the vascular network across the southeast of Wales, which should be reaching a conclusion within the next month, and we will be having the business case to a board briefing, which will convert into a board meeting. Once we have received it, we will know when we're going to take that action, but we haven't received it yet. It's a highly complicated business case, and it must be well drafted, particularly in terms of the benefits and the improvement in standards to which we ascribe and over what time. So that is basically the additional meetings that I've been attending over the last 2 months, and I wonder if anybody has any questions. If not, could we move on to patient experience and public engagement, and Gemma, the report from the Aneurin and Bevan Community Health Council?
Thank you, Chair. Good morning, everybody. Apologies for the lack of a formal CHC report this month. We've got a number of projects coming to their conclusion, so it would make more sense for me to bring a full report to the next meeting. But with thanks to Richard for popping my current concerns on the briefing that's in your papers today. We've recently undertaken our first CHC visits to the emergency department at the Grange. I just wanted to thank the staff for welcoming us and our teams through the whole week in August, where we went from the 16th, Monday the 16th, right through to the Sunday. The teams were very welcoming, very open and honest with our visitors, and we were able to speak to 84 people over the course of the week. And whilst that doesn't sound like a lot, we did glean some really meaningful feedback, and our report will be with you really soon. It was very overwhelming that people were extremely complimentary and supportive of the care and the approach of staff in the unit, whilst that they could still see the extreme pressures that the staff were facing. So we do have some positive feedback to give the teams. But understandably, the length of waits and ambulance handovers shone through quite strongly, which you'll see in the report when I'm able to share that with you. But at the moment, we continue to be concerned about ambulance waits at the front door, the capacity of the ED unit, because we know that more people are attending the Grange than expected as self-presenters. And we're continuing to hear week on week through our surveys from people about access to primary care and waits in the community for their ambulance. So as a CHC movement, we're raising these issues locally and nationally where we can. But I'm just appreciative of this health board for being very open and honest with its plans, its improvement ideas. We know that more is needed, but if the CHC can support with anything that you'd like to move forward, then we're here to do that, and obviously feedback the community's views where we can. So that's it for me. Thank you, Chair.
Thank you very much, Gemma, and thank you for your very good response to that. Somebody has got their hand up, but it's Rhiannon.
Thank you, Chair, and thank you, Gemma. I probably just wanted to highlight the fact that the CHC have been able to do face-to-face visits now. That is positive, and we always value the CHC's intervention to support an assessment of patient experience. Just based on the report, and I'm sure there's no surprises for us as a health board, and we're working very closely with the CHC on our improvement plan and the transformation of urgent and emergency care. I just wanted to highlight that we had undertaken a dignity and essential care audit within the ED department just last week. And I think it's important to highlight exactly what Gemma has said there, you know, feedback from the public whilst recognising the challenge of time waits and the issues outlined by Gemma that we're well aware of in terms of ambulance handover delays and the lack of response in the community when there is so many ambulances delayed. That actually the care for patients came out very positively within that dignity and essential care audit. I think that is important for us to recognise that whilst the services are often overwhelmed and there's a crowded department, that the staff are doing incredibly well to ensure that dignity and essential care is provided, albeit not always in a timely manner, but that we've got clinical prioritisation within the department. Thank you.
Thank you, Rhiannon, and we should be returning to this later on the agenda. Paul?
I just wanted to reiterate, actually, and to take the opportunity of thanking the staff within the hospital and within the entire service, because the feedback I've received has been exactly what Gemma has said, and also exactly what Rhiannon has said. So I think there's lots of reassurance there, and I think that's incredibly important. Could I ask Gemma one question? Gemma, those three issues that you've raised, are they the same across all health boards in Wales, or is there anything in particular that we have a problem with that nobody else has? Because I think it seems to be a huge problem elsewhere in some of them. And I just want to say the ambulance, so are those three things coming up as issues throughout Wales? They
are indeed, yes. I think for our area in isolation, the focus on the Grange has been greater because it's new, and we're all coming to terms with a reconfigured system. But certainly when I'm meeting with my CHC colleagues, these three items are at the forefront of our issues at the moment, yes.
I mean, I think that's interesting then, just from our perspective, to understand that these are not outliers. That the fact, or this, as you think you said earlier, Anne, I think that the system is under considerable pressure, and that therefore it's a total Wales operational sort of issue for us all, not just necessarily for an Iron Bevan. Thank you, Anne.
Yes. Thank you. Are there any further questions to Gemma? Tish?
Thank you, Chair. And thank you, Gemma. Firstly, just thank you for the work that you continue to do and continue to challenge us. Just on the three bullet points that you have there, access to primary care and access to ambulances, are those two completely linked things, or they different things as well? So are people highlighting issues with access to primary care, and are they highlighting issues?
Yes, they are two separate points.
Okay.
Yes, our weekly our ongoing survey, the access to primary care could be one of two things. It's either getting through on the telephone in the morning, or it's general worry about a diagnosis over the telephone, and the wait for a face-to-face appointment. And the access to ambulances in the community is the length of wait for people who are clinically urgent, that might have to make their own way to hospital. So they are two separate points, yes.
Okay, thank you. We'll look forward to your report in due course.
Thank you, Gemma. Thank you very much. If there are no further questions, could we then pass on to 3.1, the review of delegation of revenue budgets? Please, Glyn.
Thank you, Chair. Good morning, everyone. If I can just sort of remind the board that the reason this paper has come for decision today is that following our meeting back in March, which seems a long time ago, we agreed that we would review the delegation of revenue budgets on a quarterly basis. And that was particularly given I think the level of uncertainty this year around funding, particularly funding related to COVID. The fact that our service and workforce plans will need to be adaptable throughout the year, and that links to some of the conversation we've just had about extreme demand and pressures on the system. And then the third area is around confidence around the level of savings that we think we're going to deliver this year. So as a result of that, the board will remember that we reviewed and approved budgets at Q2, which was our July board meeting, and we agreed that we would review them again at the September board meeting. Since that time, we've had some additional certainty around revenue funding, with the announcement from Welsh Government that there'll be an extra £551 million for the NHS this year. Specifically 441 million of that to support the COVID response during the course of this year, and 140 million relating to COVID recovery. It's probably important to emphasise and say that this funding is non-recurrent. So it is funding that is only available this financial year to support those additional non-recurrent costs, particularly around responding to COVID, but also as we implement some of the recovery plans. So we know that funding is available across NHS Wales. At the moment, we haven't had details of how that will be allocated out to individual organisations, and we're anticipating that we'll be given that detail and notified by the end of September. So we are assuming that funding will be allocated based on the financial plans that each health board and trust in Wales have submitted to Welsh Government. So these are the plans that were submitted by the board back at the end of June. Fundamentally, our financial plan hasn't changed that much, and therefore we would, I think it's reasonable to anticipate that out of that funding allocation secured for the NHS, that we will have sufficient funding to deliver our plans for this year. It still remains a bit of a risk, obviously, because we don't know that level of detail. Therefore, in terms of this paper, Q3, we're proposing to allocate out to budget holders another £10.8 million, and this relates to the response to COVID. And in Table E in the report, it makes reference to this, but also in Appendix 2A, you'll see that there's a further breakdown of how that £10.8 million would be allocated. So it's covering things like additional PPE costs, contact tracing, mass vaccination services, and so on. And again, I would say it's important to note that this is non-recurrent funding to support one-off costs for this year. The budgets that we're proposing for Q3, they make an assumption around the delivery of savings. So I know that we had a question previously about savings and how they feed into the budget setting exercise. So when we set these budgets, we do it on the basis that when savings are realised, it will result in a reduction in costs or spend. And by doing that, it will enable budget holders to manage within their budget. So that's how savings are represented. At the moment, we're assuming that we'll deliver savings of about £16.6 million this year. And that's mainly in areas like reduction in things like medicine costs, contracts for goods and services, continuing healthcare packages of care. And again, I think the finance report later on summarises some of those areas. So those are the sort of areas where we would expect to see a reduction in spend that should then help bring it in line with the budgets that have been set. So I hope that sort of answers the questions that we had beforehand. In terms of reserves, you'll see that we're holding quite a high level of reserves at this stage. And again, that relates to the fact that our financial plan assumes that we will receive a fairly significant amount of funding at the end of September when Welsh Government announce how the extra money will be allocated. Until that time, we're holding it in reserves until we've got that certainty. And what I'm proposing is, subject to the board approving this delegation of funding, that we would look to then allocate the further funding out following that announcement or notification at the end of September. That would be allocated out in line with the plans that were submitted back in June. And essentially it allows budget holders then to focus on delivering those services within the agreed budgets for the remainder of this year. So I really just want to sort of end by asking the board to actually agree the level of anticipated funding that we're assuming to deliver a balanced financial plan for this year, to confirm those additional budgets for Q3, and obviously to note that at this stage, because we don't know the detail around how the money will be allocated, there is still a level of risk around the COVID funding that we're assuming. And then I'll be looking really to update the board at the next board meeting on hopefully the money that we have secured and how we've been able to allocate it in line with plans. So happy to stop there and take any questions.
Thank you very much, Glenn. That was very helpful in very difficult circumstances when you have such a high level of uncertainty around it. And I think it is very wise to keep a substantial level of reserves at the moment, because we don't know what's going to happen next, really, and that you've got to plan carefully for the inevitable. Paul, and then Shelley.
Just to say, I think this quarterly assessments process is incredibly helpful, because it does give us a sort of a snapshot of that particular time of what's happening, and also to get some information in about what funding is going to be made available to us or has been made available. So can I support in its entirety what's been suggested? I think it's eminently sensible at this particular time. We've got money in reserves. We have made that risk assessment across the entire sort of organisation in that sense. So just to be supportive of what is being proposed, and then in the next quarter then we can get an update, and by that stage we will have had some further information in relation to the COVID funding, etc., and that then puts in another position for us to review then. So I think that the cautious approach that we've developed is at this particular time is fully proportionate and reasonable, and an opportunity, I think, to thank Glyn and the team for putting this together. It's incredibly difficult times at the moment with regard to all sorts of happening, and I think that the financial plan that's been put forward, I think, is very good indeed, and I think it should be appreciated, really. Thank you.
Thank you, Paul. Shelley?
I was going to say, obviously, I support the recommendations. I think that's a very sensible approach to take, as Paul has already said. And the other thing is, it's mentioned in the report, but obviously at the Audit and Finance Committee, we are going to sort of keep an eye on the savings aspect, and we're going to have a bit more detail, so as we understand where these savings are potentially coming from. There was one question, though, Glyn, that occurred to me when you presented, and that was obviously quite a lot of the anticipated savings are coming from medicines and goods and services. And I just wondered, with the current problems that are being reported in terms of supply chains, generally costs going up, does this make those, I mean, logically it would make those potentially areas that where it's likely there's going to be more risk that we're actually going to achieve those savings, or do you think we're still going to be able to do that? I know it may be the question you can't answer, Glyn, but it just suddenly occurred to me.
No, it's a very good question, Shelley, and a very relevant one, I think, and we will probably see more of this uncertainty, I suspect, as we go through the next few years, probably. I think it's important to say the savings that we've identified are those that we're confident will deliver this year. As to whether in the future we may have problems around things like gas prices, for instance, it's highly likely that will be a financial pressure in future years. What we tend to do is the way that we procure some of the contracts like gas and other sort of utilities is we tend to try and build in some protection in the short term so that we don't suffer from short-term volatility in prices. However, I think your point is very relevant that over the medium term, we may actually see an increase in some of these costs, which we will have to try and manage as a health board.
Glyn, could I just, sorry, Anne, could I just have a quick follow-up to that with, if that's okay?
Yes, certainly.
Yeah, sorry. Glyn, I'm glad I raised it now, but I think probably therefore we probably do need to be looking at the transformation of services in terms of driving efficiencies out, because I think that's probably where we're going to get a more sustainable approach, because obviously there's going to be volatility, as you've mentioned, in the market. So obviously, and that's, I think, what we're trying to focus on at the Audit and Finance Committee at the moment. So thank you very much.
No, I would endorse that view, Shelley, definitely. Paul?
Could I just ask you, you raised the issue of gas. I was going to ask about the CO2 situation, Glyn, and currently the effect on the hospital at all, because I know that I read a newspaper article talking about the bigger issues for the food industry, but then it mentioned hospitals as well. And I just wondered if there's a funding issue or anything, or any sort of related concerns we have about that, gases and prices on that side of things.
So at the moment, I'm not aware of any issues either in terms of CO2 or wider gas prices or supply at the moment. I'm not aware of any problems at the moment. I do think, as I mentioned, the way that we procure some of these things, we try and build in protection in the short term around fluctuation in prices. However, if there's an underlying increase in things like carbon dioxide costs and gas prices, unfortunately, I think the NHS is exposed to it in the same way that industry and residential consumers are, really. So I think we've got an element of short-term protection. Obviously, any sort of supply issues, if they did arise, I think the NHS would generally be treated as a priority sort of consumer or customer, if you like.
Yeah, thanks for that. Really helpful. Thank you.
Thank you. Are there any further questions to Glyn? Then can I ask whether or not we're happy to approve these recommendations and his report? Yeah. Yes. Thank you. And of course, as ever, Glyn, we will thoroughly endorse the proposals that you have put forward to us, and of course keep our eye on whether or not our spend actually represents good value for money, because we will be tested on that at the end of the year, won't we? Thank you. Thanks very much.
Thank you.
Might we move to 3.2 final pharmaceutical needs assessment, and that we had this the original report a couple of meetings ago. Very informative as it was. Really helpful report. Now Sarah will bring us up to date with what's happened next.
Thank you, Chair. So the board approved the draft pharmaceutical needs assessment that we're required to produce legally, and approved the formal consultation process starting from the date of that board meeting. And this report is to provide the board with the conclusions from the consultation and to seek the board's approval to the final version of the pharmaceutical needs assessment, which is attached to the paper today. Jonathan Sims has joined us again, who will summarise the final findings. But before I invite Jonathan to do that, I just want to put some context into the discussion for the board, which is that community pharmacies are a really important part of the primary healthcare system in our most socioeconomically deprived communities, and therefore in reaching a decision today, I think we should be mindful of our duty, our socioeconomic duty that is we're now asked to consider from the 1st of April this year. And therefore the cover report has gone into some detail about how the consultation has engaged with those communities in addition to the statutory consultees. And you'll see that there is a list of local engagement events, but also we use the Integrated Wellbeing Network programme to engage with communities in the areas where that programme is active, particularly in Blaenavon and in Newport. So I'm not going to suggest that it's a perfect representation of all of our socioeconomically deprived communities, but I do think we have heard their voice, and that has been considered in the final version, and in particular also a response using the easy read version that was available for people to use as well. So the board will reach its own conclusions, but I would suggest that we have endeavoured to hear the voice of our most socioeconomically deprived communities in this consultation. At that point, I'll hand over to Jonathan.
Welcome, Jonathan.
Thank you both. So in terms of the outcome of the consultation, I think there's a broad consensus that the conclusions of the draft P&A were confirmed in terms of no gaps via pharmaceutical services. There are a range of amendments which were included within the Appendix K summary paper. I think it's very pleasing that some of the original identified needs, particularly for enhanced services, we've managed to remove following consultation, because a lot of contractors have come forward to provide additional services in smoking cessation and emergency hormonal contraception. So they are no longer needs. So that was a very positive outcome. You'll remember that we'd identified 2 future needs for new pharmacies based on population growth with housing developments, and they are the Glanllyn development within Newport and the Mamilers Urban Village in Torvine. Both of those are still identified as future needs, but we have, following the consultation, changed some of the triggers of when those new pharmacies will be required, listening to comments that we've had fed back. And in terms of the Glanllyn development, particularly the location of the pharmacy within that development has been more closely specified following the consultation from Boots Pharmacy regarding their pharmacy within the Spitty area. So that's been confirmed. So those are the main changes that have taken place following the consultation, and as Sarah said, we're now clearly looking for approval to meet our statutory obligation by the 1st of October.
Thank you, Jonathan. Are there any questions, Tej?
Thank you. Just a comment and a question, if I may. Comment. I did notice the particular focus on engagement in particular areas that are socioeconomically challenged. You might have expected that, Sarah, and I was really pleased to see that and to see the range of communities that had been engaged with. You're absolutely right. Pharmacy is a trusted place for people to go to. So thank you for that. My second question is around how, as we continue to deliver our clinical future strategy and more of our services are out in the community, and we work with pharmacies, how we continue to assess their capacity on an ongoing basis, because they are stepping up to support the community. Some of those interactions will require, for example, consultation space, and increasingly, as they're supporting us in our work, is there a case that we might have capacity issues? So, for example, I noticed that some pharmacies are absolutely ram-packed with appointments for flu vaccinations, and that could be staffing issues, it could be space, it could be all sorts of things. So I'm just thinking about into the future, how do we plan for that and assess capacity within the system?
Okay, I'm happy to answer that. I think particularly looking at the issue of flu vaccination, community pharmacies currently are sort of a minor provider in the service. We have pharmacies that probably deliver 10% of the total flu vaccination programme within the health board, but recognise that that's a very important additional service that patients choose to use community pharmacy for. Historically, I think these type of new services that are coming through haven't been appointment based, and in terms of assessing capacity, I think that's an important thing going forward, that individual contractors will need to think about their current flu orders that they have from year to year, and also the demand on their services. I think we're at a crossroads really in terms of these new type of clinical services that pharmacies are providing, and part of the Welsh Government strategy is to try and focus on reducing the dispensing volume to free up more time to allow community pharmacies to provide these kind of services. So there has been a report commissioned looking at a range of issues, for example, of products that should no longer be on prescription, but also an issue on what the prescription duration is. So moving from 28 days to 3 months, that kind of thing, which will free up capacity. That's got to be worked through at the moment to make sure that there's a financial compensation, I suppose, for contractors, that they don't lose out as we move to this new programme. So I see in the future that once those changes are put in place, that then the community pharmacy business model would need to adjust to look at things like additional consultation space to provide those clinical services. So I think we're edging towards that, but we're not quite there at the moment.
Thank you. I think that was really helpful, Jonathan, to describe the future model. Paul?
First of all, can I say I thought it was an incredible piece of work there with the detail, and particularly on the equalities agenda, I think has been superb. I mean, it's incredibly comprehensive. That's the first thing. Secondly, I think it's important, and I think you've addressed this within the report, that it's not one size fits all, because I think there's a very much a sort of a localities agenda, and that's the question I wanted to ask really. Whether or not the report is incredibly helpful to us in terms of the data and the material. Does that get fed into any localities meetings, for example, or the clinical directors of the localities, so they can look at it and then plan to ensure that there's future developments happening? I just wondered, because there's so much data and valuable information there, and I just wondered what happens about next steps.
I mean, we have, as part of the engagement process, included the NCNs and their planning as part of the consultation. But I think we're actually at a really good stage now, and I've referred to in the report that as part of the contractual changes, we've actually got nominated community pharmacists from each one of those NCN areas, which now can have that more detailed discussion with their NCN about the contribution that community pharmacy can make. So clearly they can use all of that data and information that we've got in the report to build into NCN IMTPs and really to, you know, champion the value that community pharmacy can now bring to the wider agenda.
So that looks, so in other words, then we've got next steps being developed to make sure that we've got more development. I'm a great supporter of the community pharmacies, and I think there's probably some more promotional work we need to do to promote that to our communities. But I do think that bringing in so local authorities as well and making sure local councils are aware may be helpful. But just to say, well done for the work to date. And from what you've said, it looks as if there is a conversation going on about the next steps. Would that be fair to say then, Jonathan?
Yes, definitely.
Thank you for that.
Thank you. Emrys?
Just to echo what colleagues are saying, I think the report is excellent in getting us understanding what the circumstances are. Just one comment I want to make is if you look on page 69 when it talks about the general health needs of Gwent, and it's not just applying to the one particular area which I'm going to talk about now, but I can see there that it says on the bottom of that page that in relation to, and respect of cancer, in relation to all malignancies, is that for the period 2013 to 2017, the Blaenau Gwent had the highest European age standardised rate per 100,000 population, and Newport the second highest rate. So my point of note is that acknowledging that people living within that area will require prescriptions. I suppose what we need, the measures we might also want to consider, and it may already be considered, and I'm sure Sarah might be able to respond to this, is that the work we're doing from our public health work and our public health strategy, how that links into the possible reduction in prescribing. And I suppose that would also go for things like, I suppose, antidepressants as well, and there might be some other drugs out there as well. So it's that's the point I'm making is that the importance of identifying and correlating prescribing and the work we're doing on public health.
Thank you, Emrys. Sarah?
Thank you for that question. So I think it's linking to Jonathan's point about shifting the volume of activity in pharmacies from dispensing towards more of a range of services to support population health, well-being and care in the community. And a big driver of that inequality is smoking. So the difference in smoking prevalence between Blaenau Gwent and Monmouthshire is significant. So as the report says, the great thing about community pharmacies is that they're in the middle of their communities. They're open flexible hours, often 7 days a week, and therefore they can provide support to people in a very different way to a GP practice, for example. So I think that, but in terms of the strategic objective has got to be equity of uptake, so that we've got, with smoking cessation, that we move to smokers in any one community. What kind of proportion of that number do we need to see accessing services each year? It would be the historical target for us as a health board has been just the number of smokers who have attempted to quit. Well, that could be, they could all live in Monmouthshire. So I think I would hope that with the Minister's interest in preventative healthcare, that we might move to a focus on equitable uptake that meets needs. So it's the inverse care law, really, isn't it? That actually uptake of services reflects the level of need in the community. And that would be true of smoking cessation, but it would be very much true of screening as well. I think the role of community pharmacies in either providing but also promoting services, and there's actually no reason why community pharmacists couldn't be doing blood pressure checks. They could actually do the wider cardiovascular health check that we were doing through the inverse care law programme. I think, as Jonathan's described, that the rate limiting factor is going to be the shift from a historical model to a modern model, and that's why with this pharmaceutical needs assessment, we've tried to use it as an opportunity to describe where we want to go with community pharmacies rather than just do something that meets the regulatory requirements, because I think their community pharmacies are absolutely vital to improving health and access to healthcare in our most disadvantaged communities.
Yeah.
It was a bit of a speech. I answered the question.
Sorry?
I answered the question because I got onto my.
Well, it was probably your answer was similar to the way I put the question as well. So, but thank you very much for that, Sarah.
Tish?
Yeah, sorry. I just feel I really need to, thank you and endorse this report. I'm really glad we're having this strategic longer term conversation now, before we find ourselves in a position where we are asking pharmacies and pharmacies are stepping up to the mark to support our communities in this way, and then finding that that for some reason the system's not working. So absolutely endorse this report. Thank you for it. It's very comprehensive, and these conversations.
Thank you, Tish. Are there any further comments or questions? Well, I think you can sense the enthusiasm that the board members have for the way in which this report has been compiled and the diligence through which you've consulted on it and then made changes. We were enthusiastic last time. I think that has been reinforced this time. So are we happy to agree to the pharmaceutical needs assessment as required under the regulations?
Yep.
Thank you. And we will be very happy to receive reports on progress over the next couple of years, please. Thank you.
Okay, thanks very much.
Thank you very much, Jonathan and Sarah. Can we go to 3.3, the WISC Joint Commissioning Future New Services? Glyn. Glyn.
Looks like he's frozen, Anne.
Yeah, yes, frozen.
I'll just go and check on him now.
Thank you very much. He won't be a second. I can hear them moving. Thank you, Glenn.
Apologies for that. I've lost my camera and my microphone, so I was talking to myself for a while. So apologies, everybody, for that. So the paper that you've got here relates to commissioning of some specific services where we're proposing that they would be commissioned by WISC, the Specialist Services Committee, on behalf of the Health Board. The two areas of services that we're proposing are around liver, biliary and pancreatic services, and the second area is specialist pediatric orthopedic services. So the paper sets out what the current commissioning arrangements are, and I think it's important to say that at the moment there's a bit of a mixture of Health Board directly commissioned services and services commissioned via WISC. And really the paper is proposing that in order to sort of better align the way that we commission liver biliary services with pancreatic services, that we propose that they're all commissioned through the WISC commissioning mechanism. This is it's probably important to say this is a subcommittee of the Health Board, so the Health Board is still has that overall commissioning responsibility. In terms of the second area, the specialist pediatric orthopedic services. This proposal is very much about how we commission these services in a more sustainable way going forwards, not only for our health board area, but also across Wales. And again, it's proposed that initially we would look for service specifications to be developed. So in the case of specialist pediatric orthopedic services, we'd be asking WISC to actually develop those service specs first of all, and then subject to what they tell us and what we would want to support as a health board, we would then ask WISC to commission on behalf of the health board. The second area then is around what we would call non-specialist services, and we're proposing that a service specification will be developed with support from the National Orthopedic Board, but it would still be commissioned by health boards. So by doing this, the service specifications for both specialist and non-specialist pediatric orthopedic services should be complementary, so they should take account of each other and fit properly in terms of commissioning across the whole range. So the paper hopefully is fairly self-explanatory in that respect. It's really aiming to try and put the commissioning of these services on a more robust footing going forwards, both across NHS Wales, but also for our health board area. So through this paper, I'm asking the board to support these recommendations, which effectively would mean delegating commissioning responsibility to WISC as a subcommittee on behalf of the health board. So I hope that makes sense, but happy to take any questions.
Thank you very much. Thank you very much, Glyn. Are there any questions to Glyn? Paul?
No, I think the paper is very self-explanatory, and I mean, what was particularly helpful, I thought, was the 2 letters from Judith as chair of the Health Collaborative, which I think explained it further. So I think it makes eminent sense to look to, for those services to be considered in a particular, helpful way. So I would support what's being proposed.
Thank you. Are there any further questions? Could I just ask, please, what does the Wales Orthopedic Board do, and to whom does that account?
So I mean, it's a national board. Essentially, it is accountable through the national arrangements to health boards. So it has national cross Wales expertise on orthopedic services, and that's why we would be looking to the National Orthopedic Board to help us in developing that service specification. But I think it's important to say that these service specifications still need to be agreed and owned by the health boards, for which we have responsibility.
Yeah, good. That's helpful. I have to say I'm very surprised that those services have not already had a specification which is common. So I think it's a real good step forward in this instance. Are we happy to accept the recommendations? Yes, thank you. Thank you, Glyn.
Thank you.
Well, Welsh Language Annual Report, please, Sarah.
Diolch, Chair. Rwy'n falch iawn. I'm very pleased to share with the board our Welsh Language Standards Annual Report, which addresses our statutory duty to provide a yearly account to the Welsh Language Commissioner against the compliance with our Welsh language standards. The report reflects the work undertaken today to progress the bilingual skills strategy, which aims to promote Welsh as equal value to the English language, including opportunities to enhance Welsh language awareness and training, and some of the work we've done with partners within our communities. The report also specifically addresses particular requirements from the Welsh Language Commissioner, including the workforce profile in terms of Welsh language skills, the training that's been provided, and any complaints which we have received. Our ability to make positive progress over the last year has really been supported by the recruitment of 3 additional Welsh language officers, which has enabled us in particular to increase our Welsh language awareness and training. And in particular, we were able to respond to provide bespoke training to mass vaccination centres, and also provide information in terms of the COVID vaccine to patients through the medium of Welsh, which was really positively received. We've also been able to increase our bilingual communications through bilingual web pages and increased social media presence. And our team of Welsh language officers have been really proactive in being able to undertake assessments of local services and their ability to promote what we call the active offer, which is allowing Welsh-speaking patients and Welsh-speaking members of the public to be offered the opportunity to converse in Welsh without having to be asked. And that has been really supportive in the development of local action plans and local ownership of the Welsh language compliance. We've also included in the report some of the work we've done across our communities in collaboration with partners and specific projects such as Ffrind i Mi and Cymraeg i Plant, really supporting the Welsh Government Welsh language aim of having 1 million Welsh language speakers by 2050. Within the report, we're also really pleased to share specific staff story of David Chaffee, a long-serving switchboard operator who has taken the opportunity to learn Welsh, and really recognising the importance of being able to have that immediate response through the Welsh language has in terms of patient experience. Through the next steps, we plan to build on this progress, specifically concentrating on the active offer, recognising the value that that has and the impact that that has on patient care and patient experience. And contained within the report is reference to a research project which we are currently undertaking, which really aims to increase awareness of the public of their right to receive care through the medium of Welsh, and also to understand the impact that receiving care and communication through medium of Welsh has on overall patient experience. So that's a brief summary of the report which has been shared, and the board are asked to approve the report ahead of our obligation to publicise the report by the end of this month.
Thank you, Sarah. Are there any questions to Sarah? It's a comprehensive report, and I think we're all very pleased indeed to note the improvement and the progress that has been made since the last time we received the report. So that's really very, very commendable. Thank you, Sarah. Paul?
No, I think it's a very timely report, really, and in terms of sort of where we are with, the importance of the Welsh language and ensuring that we are compliant with all that's been required. And I think what this proves is that we're on a journey, and actually the active offer and various other things that are made available, I think, are all incredibly helpful. So I think that it's a very thoughtful, thought-provoking report, incredibly helpful at this time, and to thank Sarah and the team for all the hard work that they're doing to, with regard to this report. And it does read very well, and with data and information, which I think is very helpful for us all to understand where we are and where we hope to be. So just thank you very much, Sarah, and to your team as well.
Thank you. Are there any further comments? There are a couple in the chat bar, which are extremely commendable. Okay, so we are happy to endorse and adopt this report in line with our responsibilities. Thank you.
Thank you.
And thank you, Sarah, and your team. Items for assurance. The first one is the Nurse Staffing Wales Act. Rhiannon.
Thank you, Chair. And just to highlight, I believe the Board Secretary has raised that this item is actually for approval, not assurance. So I am looking for the Board to approve the report. I am pleased to present this paper. It outlines the Health Board compliance to the requirements of the Nurse Staffing Levels Wales Act. This is mandated. It's a 3-year report. And this is our first one since the implementation of the Act, with the format prescribed by Welsh Government. The Board received the annual report on nurse staffing, which was for assurance in May 2021, and that was supported by the staff story. Colleagues will remember Beth Spence, our Band 4 assistant practitioner. There's a significant amount of detail within the report, and much work goes into the management and oversight of the Act and to ensure our compliance as an organisation. I think it's important to highlight that it's well known and evident that safe staffing levels for nursing impacts positively on patient experience and of course patient outcomes, and the Board will be aware that Wales is the only nation to legislate on nurse staffing levels, with the Act indicating the Board's responsibility and indeed duty to make provision for appropriate nurse staffing levels, ensuring that there are sufficient nurses available and that they're enabled to provide time to care, which is section 25A of the Act. The requirement extends to all care environments, whether we're providing or commissioning nursing care. So the purpose of the 3-year report is to essentially tell a story. It needs to show our approach to the nurse staffing, how we monitor compliance, our recalculation process and the associated metrics, which are all well documented within our organisational framework for nurse staffing levels. The report outlines our organisational preparedness for the extension of the Act to include paediatrics, which actually comes into force next month, and our ongoing work in relation to health visiting services, district nursing and mental health nursing. So just to reiterate, there's a significant amount of work behind the scenes to ensure our preparedness. The Board will be aware through previous reports that COVID has had a significant impact on nurse staffing and other staffing within the organisation, but that we have been agile and I would say pragmatic in ensuring compliance with the Act, whilst also noting the dispensations that have previously been agreed by Welsh Government. It is incredibly arduous to monitor wards through our surges, the COVID surges, because of the constant repurposing of wards. And what we've done in those circumstances is ensure professional nursing judgment is the overriding factor for determining staffing levels. There's been enormous effort to reduce the previous high nurse vacancies through workforce redesign, our targeted recruitment and global engagement. This has taken us from a position of 350 whole-time equivalent registered nurse vacancies in the summer of 2019 to an incredible position at the end of this month where we'll have circa 50 whole-time equivalent registered nurse vacancies. I'd probably just want to emphasise this is an incredible achievement against a backdrop of COVID, and if it wasn't for COVID we would be in a very positive position with regards to nurse staffing. I think the efforts of the nursing and workforce and OD teams are to be applauded, and I'd like to make a particular mention to Linda Alexander, Deputy Director of Nursing, and Sarah Simmons in her previous role as Deputy Director of Workforce and OD, who've worked diligently on this agenda. I think the metrics and the quality indicators are included in the report. They are healthcare acquired pressure ulcers for 3, 4 and unstageables, falls resulting in significant harm and never event medication errors. Additionally, complaints have been included, which is a relatively new metric now, and relates to nurse staffing levels being identified as an issue within a complaint. I think it'd just be important to highlight that direct comparisons between the years within the tables included it wouldn't be appropriate. That the importance of that is because of the significant changes that have happened year on year. So it isn't just about the numbers. And just to highlight that in reality it is quite challenging to determine if staffing levels are causative for some of these metrics, particularly a factor in complaints, where often this is about multidisciplinary care and the complexity of a complaint. To summarise, this is a comprehensive report. It covers the last 3 years where we've seen significant work and progress with regards to the Nurse Staffing Levels Wales Act, particularly in relation to the necessary reporting processes to provide assurance to both the public, our board and Welsh Government. I think the Health Board has absolutely embedded the biannual reporting process, which is now considered business as usual. We've got regular review and consideration as to how the process can be enhanced and add value to workforce planning. And we're absolutely ensuring the best care is possible that is provided for patients, whatever that setting. Thank you.
Thank you very much, Rhiannon, and thank you very much for the comprehensive nature of this report and the huge efforts that have been put into place to reduce the very high levels of nurse vacancies over the past years. Really is a remarkable piece of work, and thank you to you and your team for achieving that. And you've had our support all the way along to make that progress, so thank you. Paul?
Just to say, when there's challenges, one looks for opportunities, and I think it's an outstanding example of actually rising to that challenge. And I think that what I've been incredibly impressed with is the creative and innovative ways in which things have been looked at to try and develop and ensure that we've got a very able and talented workforce. And the whole idea of the apprenticeship scheme as well, which is something that's being developed and embedded. And we've also got to remember this has been a very difficult time for hospitals and I think the health service in Wales with the COVID. But not only that, on top of that, I think the way that the nursing has been handled and supported through the transformational changes with regard to the Grange and the local hospitals, and I think just an opportunity, I think, to say to Rhiannon and to your team, very well done. It's been a very difficult time, and this report, I think, evidences the superb work that's been undertaken, and I think we should congratulate you and your team on that work. Well done.
Thank you, Paul.
Thank you.
Are there any further questions or comments? Could I just ask a really naive question? What happens to an area that doesn't comply with the Act?
I think it would probably be quite challenging to not comply, bearing in mind it is legislation. And there would be reputational issues from a health board perspective that would obviously be raised from a Welsh Government perspective. I would just see that it'd be very difficult not to comply, and I think the duty of the board is to ensure that we do everything possible to ensure appropriate staffing, and we do that. We know that we have occasions where the staffing does not meet the required roster. Our duty is to ensure that we've done everything possible to cover that required roster, and we can demonstrate that we do that. And I probably acknowledge the support of the board over the past couple of years, certainly since I've been in post, where the board have been supportive of creative opportunities that have been put forward and workforce redesign. This is not about reducing registered nurses, but it was about recognising that we had such a significant gap that we had to do things differently. But I think it would be a very serious situation for us as an organisation, or any organisation that was not compliant, but it's incumbent upon us to demonstrate that compliance.
Now, I wasn't suggesting that we weren't going to be compliant. It was just, what happens, and I think we have to commend the team on the innovation that they instituted, given the issues with which they were faced, to ensure that safe care was preserved at all times. So thank you for that. Emrys.
Again, just to echo, I think it's an excellent report, and I have to say, Rhiannon, I've always been impressed in the way that you've approached the challenges that you've had to manage through nursing, and certainly over the last few years, and particularly over the last year. My only comment I just wanted to add to the comprehensive report that you've shared with us is that the one thing I do pick up in there, obviously, is demand and acuity is changing. So as a consequence of the demand and acuity changing, I assume that going forward, to future-proof our system, that we would have to have the right, it won't be just nurses, we need to have the right skills in place to be able to respond to that demand. So two questions, I suppose. One, are we comfortable that the process we have in place helps to support the planning of the workforce that we require going forward, recognising the things that we've had to manage, and you particularly have had to manage over this past year? And the second one then is, I suppose it's just a supplementary to that, is that do we have enough nurse training places to meet that demand going forward?
Thank you, Emrys. I think that they're excellent questions. My own view would be that workforce planning is a skill. I think it's an art and a skill, and over years it has been, I think, somewhat of a tick box exercise as opposed to it being a more sophisticated exercise, which is truly multidisciplinary. I think we're still operating in elements of silo, so workforce planning for nursing, workforce planning for therapies, although I think that has moved, and certainly some recent discussions with HEIW regarding a refreshed approach to workforce planning, which was associated with nursing, but absolutely took into account the multidisciplinary nature that's required to explore not just nurse requirements and staffing requirements from an NHS perspective, but more broadly where we commission elsewhere. So taking much more into account the requirements for independent sector nursing homes, but also social care as well. So I think the focus is shifting. I've seen that much more in the past 12 to 18 months than I've seen previously. I think for nursing, we're in quite a strong position in terms of workforce planning, enabled by the Act, if I'm being honest, because that has clearly directed the requirements. So I think we're in a stronger position than some other professions in terms of workforce planning. I still believe there's a lot of work to do, and I think there's a lot of work to do in terms of that creative approach and workforce redesign, and we're still not quite there. There's still an element of siloed operation, but I am pleased that this is firmly on the agenda of HEIW and features as one of their priorities in their 3-year plan. Did that answer your questions?
It does answer, but I suppose that just final point there was, Rhiannon, is that in relation to nurse training places.
Oh, yes, yeah. So. Yeah, I think this is, again, we've had recent discussions with HEIW about that very issue, because in terms of the process, there's a six-step model for workforce planning. The first part of that model is that the financial envelope, and I feel quite strongly that we have to tip this on its head, because it's got to be about what we need, and the finance comes as the 6th step, not the first step. Colleagues may disagree with me, but it's not that there's an never-ending pot, but the reality of the change in patient status, the ever-increasing higher acuity, particularly in hospitals, but in community as well, the tsunami in terms of mental health needs means that we do need more. I think the only assurance I can give from a local perspective in terms of that is that we undertake the biannual calculation of staffing. We've been very vigilant in terms of the new model in the GUH and our ELGHs, and undertaken a number of challenge and support sessions in terms of the staffing requirements, particularly cognizant of the increased acuity and dependency of patients that we're seeing and what that means in terms of nurse staffing. But again, I would just want to reinforce that we and my leadership in terms of that is looking at alternative models. It hasn't always got to be registered nurses, although the registered nurse has got a very key role to play. So I think there's still work to do. We identify what we need, but the reality is the finance is not there to support the needs nationally, in my opinion.
Okay, thank you, Rhiannon.
Thank you.
Sarah?
Thank you. Just to add to Rhiannon's comments, which I would fully agree with, that in terms of nurse staffing training numbers, I think the biannual reporting has certainly supported us in being more accurate in terms of our workforce planning and forecasts. And we also work closely with our university and higher education partners to be able to look at more flexible access routes into training for nursing, and specifically working with education partners to very closely to ensure that we attract and support placement. And I think we've done a lot of work. Rhiannon has done a lot of work in the past few years to increase our training places as well.
Thank you, Sarah. Are there any further questions, comments? No? If not, are you happy to approve this report? Yeah, thank you. Moving to 4.2, the patient story. Nick?
Yeah, thank you, Chair. I think we're just waiting for Ben Oates to join us, who's the lead psychologist in therapies, who will be presenting the patient story. But while we wait for, I just thought it'd be worthwhile drawing your attention to the next paper, which really is around the NCN planning and how we are trying to bring together the services of primary care, communities and mental health in terms of that whole system view and support for patients in the community.
Nick, can I stop you? Do you want to deal with that report first then?
No, it's a sort of lead-in really to the patient story, Anne, in terms of the fact that the NCNs, through their planning cycle and through their regular liaison with myself and other members of the board, have highlighted the issue around mental health and the need to support patients more locally in the community, whether they be in crisis or just accessing those foundation tier services. So the development of services locally, including the sort of shared lives, sanctuary provision, etc., which has been led by Benna, is very much a feature of that shift in services from the traditional sort of hospital setting into the community. So I don't know whether Benna has joined us at this point. I know she was. No.
Can't see.
Can't see. She was due to come about now. I don't know, Richard, whether we've invited her.
Can you find out where she is, please, Richard?
Yes, we'll do that. But she has been invited, yeah, and she was told what time to come. And we'll check now.
Okay.
Bryony's emailed her. I don't know whether Richard, what we perhaps could do is run the video of the patient story while we wait for Benna to.
Yes,
to
that's
arrive.
a good idea.
Yeah, I could do that. Do you want the introduction with it then, Nick?
Yeah, if you just run it from the beginning, hopefully we won't get the adverts from YouTube, but
I'll try not to include the adverts.
So this is a video story of the shared lives service that was introduced last year in the Health Board. It's been very heavily featured on the media and in other sort of publications, etc. And it's a real positive story and approach to the way in which we're delivering care in the community. So here we go. We can't hear it, Richard.
We can't see it either.
You know, I can see it on mine.
Right. Can't hear it.
It's just buffering up, isn't it?
Yeah.
Can you all see it at least at the moment?
Yeah.
Yeah.
I think the problem may be that because it's linked into my computer, we may not be able to hear that. We did it before and it worked. So if you hold on a second.
Peter's telling you, Richard, you need to take your own microphone off mute when you play the video.
Might we try again?
Yeah, I'm trying a couple of different methods to actually make sure you get the audio. Excuse me a second.
Well, unfortunately, I think we'll have to pass on for the moment, Nick, because it doesn't seem to be coming through at all.
Okay, so shall I take the
NCN.
Benna, have you arrived on the meeting, or?
I can't see her.
No. Right, I'll take the NCN paper.
Please,
Chair, if
and
that's
we'll
helpful.
get
Sorry
it.
about that. I thought we'd sorted that this morning. Right, so what I brought around the NCNs, I think colleagues will probably recall that in previous years we brought the NCN planning framework and their annual plans and IMTPs to the board, either through this particular meeting, usually in the sort of summer, autumn, or through one of the committees to discuss their influence really and approach to planning at a primary care and community level, and how we use their plans to inform the divisional primary care plan, but also how that feeds through into the overall health board's IMTP. And obviously in previous years we've acted on an IMTP, and once we went into the pandemic at the beginning of sort of 2020, we've reverted to an annual plan. And I suppose, unfortunately, in some respects, some of the more strategic plans that the NCNs had described have been put to one side as they've attempted to respond to the pandemic at a local and community level. I think, however, it's really important to point out at this point, as we move out of the pandemic and into a degree of more normal times, the programme for government of Welsh Government has got a very clear priority around accelerating cluster development, and the role our NCNs will play in that acceleration is going to be quite key. So we are now moving towards a more IMTP based planning round for 2022-23, but this paper really just summarises where we are with the NCNs and the progress that they've made despite the pandemic really over the last year or so. Just to make everybody clear that the NCNs, or neighbourhood care networks, are collaborative networks which comprise primary care, mental health, social care and community provision, and they operate within the boundaries of our geographic footprint, and we have 12 of them across Gwent, split into their respective boroughs. They developed IMTPs for the first time in 1920, and they were updated last year to reflect the response to the COVID pandemic. And in looking at their strategic priorities as we moved forward, there was a number of shifts that they needed to make to respond to the pandemic, and also the sort of coming out of that period of time. And on page 2 of the report, you'll see that they've moved some of their priorities to look at essential services, the prevention of adverse outcomes, the move to be more responsive to urgent care and access arrangements in our local communities, the management of chronic conditions and the backlog associated with patients who have a chronic condition, and the proactive management of vulnerable groups and local populations who are vulnerable. And so it is with that in mind that they've developed and moved the service through over the last 12 to 18 months. And I think it's really, really important to stress the role that they've played in our response over that period of time, in particular around the maintenance of services through the early part of lockdown and the early pandemic, and then in responding when we had the vaccine availability and their delivery of the vaccine, and a good proportion of vaccine was delivered through GP practices organised through the NCN footprint. But nevertheless, whilst that's been ongoing, they've continued to drive forward the strategic agenda, and a number of the priorities that we identified in 1920 have been delivered or continue to move forward at pace through our networks, and put us in a really good place to start to develop the cluster footprints and utilising that accelerated cluster approach that's been pushed through the programme for government. So in the paper, we describe a number of developments and priorities that were identified through the NCN plans, which meet a number of the health board's priorities. And what we tried to do is really rate them in terms of delivery and where we've got to with the delivery of that programme. And you'll see from the charts that we developed that they've continued to maintain delivery in a number of areas, particularly in the development of locally based community services and the move towards the diversification really of what we deliver on a primary care basis. So we've built good work and relationships around the compassionate communities model, and that's really started to embed itself over the latter half of the last 12 months as we diversify and move to that more MDT approach in looking after patients in the community. We talked previously in this meeting about the primary care staffing model and how best we can utilise different skill sets to deliver primary care, particularly in those areas where we've struggled with sustainability. And we've introduced the MDT role in many of our practices now across the Gwent footprint, and in particular where we've got challenges with managed practices, we've had support to deliver that MDT approach. All of the practices have delivered care navigation training and alternatives for access in GP care. And whilst that's I think difficult at times for patients, it does have its benefits in shifting demand to professionals who are able to deliver, whether that be through the Common Ailment Scheme and some of the eye health examination Wales services that we offer. We've also implemented 111, of course, across the region, and accompanied with the 24/7 primary care work that we've done through the urgent primary care centres, which again have been supported by the NCNs in their development and delivery over the last 12 months. In terms of some of the areas that they've faced a challenge, some of the more service delivery areas such as eye care, specialist dental treatment and audiology services, we've not really gone as far as we would have liked in terms of the implementation of those, partly driven by the circumstances of the pandemic, making some of the service delivery and close contacts difficult for us. And as we move forward now into the winter period and into next year, some of the work that the NCNs are involved in terms of graduated care and the delivery of place-based care and care teams will be really key in the way in which we deliver our services and sustainability through the winter period. As we know, we face significant challenges, which I think we're going to pick up when we come to the winter planning paper later in the board meeting. So in summary, I think it's worth saying that despite the challenges really of the pandemic, the NCNs are really at the forefront of how we are delivering primary and community services. And as I referenced at the beginning, I see Ben has joined us, they've also highlighted the need for us to bring certainly foundation and tier 1 mental health services closer to primary and community care, so we can provide that full wraparound of service and delivery for our patients in the local community. And hopefully we can then enhance that through the work that we do over the next 12 months in terms of accelerating their development, but also building a more coherent and sustainable model for place-based care. So I'll pause there, Anne, and hopefully we can perhaps go back to the patient story and get the video running and let Benna introduce the work that she's been doing, and then perhaps take questions around both of the NCN paper and the patient story.
Thank you very much, Nick. I know people have questions on the NCN report, but if you think it would be the best thing to get a more comprehensive view, to take the video and listen to Benna before we have the discussion, then we will do that.
Yeah, just I don't know if Richard's maybe got the video working, but we were having a bit of trouble, Benna, with the YouTube video. So whilst Richard brings it up, I don't know if you want to just introduce where we are with.
Yes, I'd be really happy to do that. Oh, it looks like the video is up, which is fantastic. I'll just tell you very briefly. So this is looking at our Shared Lives for Mental Health Crisis project, which we've been running now for 2 years within the Mental Health Division in partnership with Caerphilly Borough County Council, and it is providing really community alternatives to inpatient hospital care for people when they're in crisis. For us, the work's been driven by improving outcomes and experiences for people. That's been a huge driver, and you'll see from this patient story, I hope, the way that it's impacted for Nikita, who's the young woman who's the focus of this story. So if you're ready to show the video, Richard, that would be great.
No.
We're not getting any sound, James.
We haven't got any sound.
Richard, it might be worth coming off mute.
No, I'm not presenting it. James is presenting it at the moment. I think there's a problem with the YouTube link, I think.
Can we have one last try? Otherwise, I think we're going to have to abandon it, unfortunately.
Yeah, no, that's a shame. These things, yeah. I have in many places attempted to, yeah, it can be challenging, can't it, technology? It is. Yes. It does not always run smoothly. I do have some slides briefly that I'd like to share with you.
I think that will be very helpful.
So, Nick, I think I don't know who it is that's in control of my
I'm going to share
the Shared Lives for Mental Health Crisis project.
It's tantalizingly close, isn't it? We can see it, we can almost hear it, but it looks like it's not going to play ball. So shall I, Nick, would you like to share the slides that I have? So these are just to set the context really for the experience. So the video tells the story of Nikita, who's a young woman who was admitted to one of our wards and then went straight out into a Shared Lives for Mental Health Crisis scheme, talking about the different ways in which that journey was so different for her. So in Shared Lives, you live with a carer. It's a bit like a foster care for adult scheme. So you're with the same person day in, day out. You can engage with the community. We've had people that have learned to cook. We've had people that have really valued being part of normal meals. Somebody who loved being able to do the ironing. Irons, of course, would be risk assessed off an inpatient ward. So all of the ways in which participating in normal family life and normal activity and being in the community, being able to visit their home environments and get ready for going home. People just talk about it being a very different kind of experience for them in inpatient care. And our crisis teams have been crucial to visiting those people in those placements, making sure that they're being well managed, monitoring their mental health. So it's been a really positive experience, I think, for everybody. What's been really lovely for me about seeing this through from beginning to where we are now is that what teams tell us is it's amazing because it's giving them more options and they're delighted about the impact it's had on their work. What the carers tell us is that it's really rewarding work for them. And you very much get that from the video. So perhaps we can share the link round afterwards. It's only 5 minutes, but it's a beautiful story. And what patients tell us is that it's a phenomenal experience for them and is very different to their experience of inpatient care. So Nick, if you can move on to the next slide. This particular project was picked up by the World Health Organization and featured in some best practice guidance that was launched earlier this year. We were one of only 27 services to be featured worldwide, one of 3 in the UK and the only one within Wales. So we were really delighted with that honour. Felt like a real accolade and a real privilege to be included in the launch event and all of the kind of people doing amazing and innovative things across the world. Nick, On my screen, my slide hasn't moved on. There we go. That's great. Lovely. Thank you. So that's the World Health Organization guidance. Thank you. And if you can just move on to the next slide, which has some data on how much the scheme's been used. So far, 87 people have experienced a shared lives arrangement, and we're growing the number of people who don't go via an inpatient unit. There was a certain amount of anxiety about whether this felt safe enough, whether teams were comfortable with the risk taking. So initially we had people on a ward, and then we were really clear that the patient journey would be loads better if we could assess people in crisis and put them straight into a shared lives placement. And that's what we're now doing increasingly. So we're pushing up to about half of the people that have used the scheme now going straight into it. So we've tried to take a value-based approach to evaluating the scheme. So this is our PROM, our patient reported outcome measure. So we're using a validated measure called the REQOL. And you can see, so on this slide, we've got our pre-REQOL scores and our post-REQOL scores. So higher score is better. And the brighter blue on the left is our control group, and the paler blue is our shared lives group. So you can see everybody makes some recovery over their journey, but the people going into shared lives placements are making significantly greater recovery. If you can move on to the next slide, please. This looks at, so I've got a couple of slides coming up for you, which looks at people's service use pre and post a shared lives stay. It's a slightly complicated bit of analysis. So essentially what we're doing is comparing, we're using each person as their own control. So the 0 to 3 months group would be people who used a shared lives placement within the last 3 months, and it would be their pattern of service use in the 3 months prior to shared lives and the 3 months post. And then you can see 4 to 6, 7 to 9. And what you can see is that people's admission rate, so a lot of the people that we work with in mental health have something that we talk about as unrelenting crisis. So there's a pattern of crisis going out, coming back in, often very heavy service use. So what you can see with this is that we're bringing down people's use of hospital care, of needing care. So we're reducing the crisis rate after a shared life stay because of the contribution that it's making to people's recovery. And related to that, if you can take us on to the next slide, Nick, we also have picked up a difference in referrals. So these are people's service use, patterns of service use before and after a shared life stay. So again, you can see that the onward referrals, their use of other services is reducing after shared lives, which is really heartening for us. Next slide, please.
Does that come up?
Yeah, that's lovely. Thank you. So in terms of our next steps, so we were delighted to get funding from Welsh Government this year to roll out across Sgwent, and that's recurrent funding. So that's fantastic for us. So we're about to, so far we've been operating mainly in Newport. We are thinking about whether this might have a role to play in both older adult and CAMS. There are issues currently. So the Shared Life Scheme is currently only licensed for over 18s, but there are beginning to be exceptions to that for 16 to 17-year-olds. And certainly our CAMS colleagues are really interested in whether that might be a possibility. So we're having some conversations about that. And our value-based approach to evaluation is continuing. So we're hoping as the scheme goes on and we have more people that use it, we'll really be able to demonstrate the value of this work. So that's all. That was the spiel that was supposed to accompany the story. I'm so sorry that it hasn't been possible to show the story. I think YouTube is often a little bit can be a bit challenging, so apologies about that. I'm very happy to take any questions.
Thank you very much indeed, Helen, for that, and particularly congratulations on being recognised by the WHO for this really good scheme, which is proving to make such a difference to people within our community who are very, very vulnerable. Are there any questions from the board? Emrys?
Mine's just a comment, really, Ben. Obviously, I've had several conversations with you about the work that's been undertaken here, and as Anne said, is that the recognition by the World Health Organization is quite an achievement. It's not that's no small achievement. That is a major achievement, and particularly when you recognise that only 3 out of all those of those 27 that were in that conference, and the recognition was around one of us from our organisation within the UK is quite outstanding. More importantly, though, is that moving forward in the management of crisis, this is a different model to help improve the quality of lives of individuals, and certainly what you've shared with us today helps us to understand that it's not just about bringing people into hospitals to give them treatment, as important as it is also about promoting their well-being in the community, and we're developing a service model to suit that helps us to get a better use of resources, but more importantly helps to improve the quality of life for those individuals that are coming through into crisis. So my comment is, and I've said it to you before, Benna, but very well done, and it's something we've got to sustain, maintain and help to develop when we have our comprehensive service model that's developing at the moment. Thank you.
Thanks, Emrys. And I think we'd all endorse those views. Tej?
Thank you, Chair. Thank you, Benna. Outstanding, and you know, congratulations. I think beyond the obviously significant impact on our patients and those that need that support, which is not insignificant, obviously, there seems to be a real investment in the social capital of the community, in as much as people are welcoming those that need support into their homes. I'm just wondering, and absolutely endorse that. I'm just wondering where our families, our carers come from, and what sort of support we give to them.
Yeah, thank you. That's a great question. So the Shared Lives scheme, which operates right across Wales, run various carer recruitment events. So you know, they might go out onto a kind of high street shopping centres, that kind of thing. Interestingly, so there's a very careful recruitment process. So in terms of interest expressed, you know, that they get funneled down. It's a little bit like applying to adopt. You know, there's close scrutiny on the people that apply. A number of people that end up getting through that process have been involved in care work in some kind. So I've met some of the carers. So we have some people who've previously worked in care homes, retired staff. So actually, interestingly, I'm always kind of keen to talk about this in contexts where there might be staff considering retirement options, but it's absolutely something which, you know, retired NHS or social services staff could consider. But there's a really big, wide range of people who, for whatever reason, it works for them to work from home. So yes, it can be anybody, but what's wonderful about it is they are people drawn from our community, who live in our communities, who know our communities, and sometimes the links that they're able to support people to build are really powerful in the kind of long-term recovery. I love your point about social capital, and I think that's really important. So one of the things that has occurred to me about this scheme is it's powerfully stigma reducing. You know, if we say to people that actually at a time of mental health crisis, people are vulnerable and what they need is care and humanity and compassion, and people who are willing to show human kindness and welcome them into their homes, that's a very different message, isn't it, to the message that so often gets promoted in the media around mental health issues. I was really interested in whether there was a way of kind of capturing, and I don't think there is a way of measuring kind of how we reduce stigma, but my hope certainly is that that will be one of the benefits of this scheme, is the way that it contributes to kind of community views on mental illness.
Thank you. Chair, you may also just add, you referred at the beginning of the meeting about the conversations you had with the Minister about foundation economy, and often we find that with volunteering of all sorts, and as you said, Ben, you know, people are coming from across the community. We find that all sorts of volunteering often is precursor to employment or further pursuing of education. So this kind of initiative where we are engaging with people across the community who may or may not currently be in work, who may be retired but may be earlier on in their working lives, could support again that social capital
yes.
and moving on.
Yes, thank you, Tish. Good point. Shelley?
Just thank you very much. Tish has actually covered the issue I was going to ask about the people that come forward, and is there any difficulty? And based on what you've said, I don't, presumably there isn't. But I just want to say thank you very much for coming back today, because I think probably about 2 years ago, as you say, when the service was just starting off, Chris O'Connor came to the Partnerships Committee and we saw the start of this. So from my personal perspective, it's absolutely fantastic to have you back here today to tell us about the success and the numbers of people that are going through it. So yeah, thank you very much indeed. That's what I wanted to say.
That's lovely. Thank you. And actually, I realised Tish asked me a two-part question, and I think I neglected one of the parts, which was what support do we give the carers? So can I just briefly speak to that? So essentially our shared lives, so we have dedicated shared lives for mental health crisis coordinators, and they run that, it's their role to support the carers. So essentially our crisis teams support the people that we place within the shared lives arrangements, and the shared lives coordination scheme support the carers. So it's their role to be on call for the carers, although carers also have access to our crisis teams and out of hours support when they need it. But we offer so we offer regular support groups. We're looking at training needs. So the Shared Life Scheme offers some basic training for all their shared lives carers. It's been a dilemma for us, and I guess this relates a little bit to the stigma reducing point around how technical we want our carers to see the role as being. So there's been some interesting conversations around the degree to which we train people up in models around mental health and illness, because I think there is an argument for saying actually what we're inviting people to do is use their humanity, and that seems to be working extremely well for us in terms of both carer and service user experience. But we also don't want our carers to feel out of their depth or like they're struggling. So there is an active conversation going on at the moment, just trying to consult around what would be useful. Is it that they just need regular consultation with some of our staff, so crisis team people, myself, whoever's around, just to be able to check in and ask things they're not sure about, or is there a training package that we could develop around that? So that's a kind of ongoing conversation, but making sure our carers feel able to sustain themselves in the role that they enjoy it. When you watch the video, you'll see Mags talking about the work, and it's quite clear that she loves it, that it is deeply personally meaningful for her and hugely rewarding. But we want to keep that going. We absolutely don't want carers to be burning out or to have difficult experiences or to feel out of their depth. So carer support is definitely on our radar very much.
Thank you very much indeed, Ben. It was really an inspiring story, and we're so pleased with the progress that's being made, and that we are able to roll it out even further because we've been given the support and recognition. So thank you very much indeed to you and your teams, and we look forward to seeing what happens in the next 2 years.
Lovely. Thank you very much. Thank you for having me.
And I've posted the link, Anne, in the sidebar.
Thank you very much. That's helpful.
I'm sorry it didn't work. But,
Oh, yes. Well, we're sorry it didn't work, but we shall all watch it at our leisure. Right, Nick, might we return to the NCN report, which you've presented? Are there any questions to Nick on the breadth of that report? Can I just ask something then? I think it's really pleasing to see the progress that the NCNs have made to respond to their varying population needs and requirements. And we shall, of course, be discussing this paper in the Strategic Planning and Population Health Group. To what extent are there very different approaches to solving a similar population-based problem occurring within the NCNs, or are they getting really adept at sharing practice so that we don't sort of duplicate all the time?
So I think I wouldn't describe them as really adept at this point. I think it's a maturing situation. Under the sort of leadership of Karen Gully, who's been responsible for the sort of NCN development group, we've utilised the time that we've had over the last couple of years to establish a sort of development group, as well as the NCN Leads meeting, which I think has facilitated a much more shared approach to problems and solutions. And certainly in the last, I suppose, 2 years, we've shifted our thought processes into a much more, I think, coherent approach to multiple problems. So I give an example of the at a lower level, the sort of pharmacist deployment that we managed to achieve through the NCNs, and there was at first a sort of reticence by some of the NCNs to deliver that, but actually using the leadership group and the development group, we've been able to present back the sort of outcomes of that work, which has resulted in a much more consistent approach to the delivery. And I think that was a useful learning for when we rolled out the psychological wellbeing practitioners. So we all recognised, I think, across the 12 areas of NCNs, that we had a challenge with the number of presentations for, I suppose you'd call it foundational low-level mental health, that were taking quite significant amounts of GP time and nurse practitioner time. And therefore the model that was proposed by Chris O'Connor and his team, supported by the NCNs around the PWPs, the psychological wellbeing practitioners, was adopted by 11 out of 12 in the first run, if you like. So, and subsequent, we're now seeing 1,300 patients a month through that service, which is in effect 100 per NCN. And you know, there's a real move to share learning and move the development forward. Obviously, we've got, you know, some that have developed at pace and some that are, you know, slightly behind that curve. And I think the responsibility we have is to get everybody to a level, but also encourage that active development of those that want to be, you know, front runners in all of this. And how we manage that, I think, is really quite important as we go forward. So yeah, so I think it's, you know, I wouldn't say we were advanced at this yet, Anne, but I think we are, you know, we're making good steps, and I think certainly the last couple of years have really helped with that.
Thank you, Nick. That's helpful. Paul?
Yeah, I just wondered, I mean, it's a useful report. There are 3 reds I've noticed on the report, Nick, and I was going to ask you to comment about the actions with regard to those. One's involved, I think, with dental services, one's to do with eyes, and the other's to do with falls. And I just wondered if we've got an update and sort of, you know, when things are going to happen, or what, you know, what's being done to ensure that those 3 areas are covered. And do you feel confident that the actions that are in place will ensure they're able to be delivered?
Yeah, I think some of this, Paul, was due to the fact that, you know, we moved to a sort of an essential service model, you know, during the pandemic, and therefore some of the close contact service delivery was more difficult for us to roll out at that particular point in time. And there's been a delay specifically in the eye care work, I think, which, you know, we're now looking at alternative arrangements and how we can revisit that it is a key priority. We've done some work around the sort of eye healthcare examination service, but we've got much more work to do, and I think that it'll continue to be a priority, but we need to review and perhaps, you know, revisit our approach to that. I think the same is, you know, the dental challenge has been enormous during the pandemic, and starting new pathways has been difficult when we really were only seeing people on an emergency basis. But interestingly, I think if you look at, you know, I think we discussed at the last board the investment in recovery monies, and we put quite significant investment into dental services, particularly sedation and some of the orthodontic services that are delivered at a very low local scale, we've I hate the phrase ramped up, but we really have ramped up the delivery of that in the last 2 or 3 months as we've used the recovery phase to drive some of that. So I think, I'm assured that, we were never going to achieve all of the objectives that we laid out in the last 18 months. There were inevitably with some that we wouldn't make progress with. I think it's a question now is as we move through the next 3 or 4 months, as we revisit planning and the planning framework really for the NCNs into the next year, that we reprioritise, and some of those things may not be a priority as we move forward based on the learning of the last 12-18 months.
I just wondered particularly about dentistry, because again they've got the COVID restrictions, and that's been incredibly difficult for dentists to be able to operate within the sort of system. And I wondered where dentistry was with regard to the COVID restrictions, because I know when I visited the dentist several months ago, I had to fill in a form about this, I had to fill in a form about that, about COVID and all sorts of things. And I thought it was, it was quite not intrusive, and it was necessary, but that was just one thing, and it took me a while to navigate it all. And I'm just thinking, how does that, how has the COVID restrictions affected that, and what is there anything that can be done to alert the public about what they need to do as well with regard to access?
Okay, so and you make a very good point, and dentistry is probably one of the areas we receive the most concerns, I think, from the public about and access. And certainly at this, as you probably know, I'm a member of the primary care recovery group that discusses these issues with Welsh Government, and I raised the dentistry issue on Monday with them, because I think there's a lack of understanding for the public around access to core dental services such as checkups and the hygienist sort of services, which are currently restricted for the community dental NHS only services, due in part to the risk assessment and the advice that's issued from the Chief Dental Officer and Welsh Government. And they haven't revised the SOP or the advice, despite the fact that we've got revised advice for things like having a visit to the barbers or other reasonably close contact services. And if you look at the actual activity in dentistry, so, the recovery has been really quite good in some aspects. So for emergency services and for the more the AGP, which is the aerosol generating procedures, we're now back at about 80% of pre-pandemic levels in terms of activity. The areas where we're really struggling to get back is in that low-level checkup and first fill-in stage, where we haven't got activity back up to that level. And it was quite interesting, the conversation with Welsh Government. Well, we wonder why we haven't got back to that. Well, it's because we've not lifted the restrictions on the ability for people to access checkups. Now, if you're with a dentist that is both private and NHS, then a lot of them are operating a wait in the car, fill in a form, come in for a checkup sort of service, which is probably what you've experienced, Paul, in terms of the form filling, etc. And there is excessive form filling because, of course, nowadays we're not necessarily registered with the dentist. You can access, dentists, as and when you need to have treatment. So I think it's a difficult position for us at the minute. It's difficult to defend the operation of the standard operating procedure as it stands, and we're actively trying to encourage Welsh Government to lift some of the restriction around giving people access to preventative services such as having a checkup or the check for oral cancer, etc.
No, that's really helpful though, Nick. And I mean, what's been particularly helpful is the fact that you've raised it and flagged it up, because I was under the impression, I was thinking lots of advice on certain services, but that was one that was missing. And people hadn't felt briefed on it really and didn't understand. And I think particularly with children and older people, when it comes to looking at oral health, I mean, they can have significant impact if you're not careful. It's like, again, a perfect storm developing if we're not careful. And I think dentistry is one of those areas we don't normally have much conversation about at board level, because a lot of it is acute. And we do talk community services, but I specifically wanted to raise a dental issue there, because I know some of the dentists have been tearing their hair out really with regards to where they are with regard to this particular situation. So if we're following it up and seeking further guidance and help to get this moved on a bit, I think that's incredibly helpful. And thank you for that.
And just to say, we've also invested quite a considerable amount of resource from our recovery plan early doors into dentistry. So I think it's in the region of £500,000 we put into support enhanced services. We also invested considerably at the beginning of the pandemic in emergency appointments. So we virtually doubled the number of emergency appointments available across the area at the beginning of the pandemic, and we've been able to respond in those ways as well.
I mean, that's fantastic, but I think there's still that gap.
Oh, there absolutely is, absolutely.
Which is why I'm encouraged by what you've said and what you've done, because I think we need some further advice on being able to just unpick the particular challenges there. I'm grateful for that.
Thank you,
Thank you, Anne.
Thank you. Shelley, have you got your hand up?
Yeah, I did. It was just an observation or a request, really, Anne, if that was okay, from Nick. I mean, obviously the report is great, and it's really lovely to see that here now. So it brings everything together. But Anne mentioned that obviously we'd be discussing this further at the strategy and planning meeting. What I was going to ask is that when we have that sort of information, it would be helpful to understand where some of these developments are actually already in situ, and then where they're planned to be rolled out to, because obviously at the moment you could read this to think that all these things were all going along under all the NCN. So it was just, I think, a bit more detail around where the key areas, and understanding that because of need, there will be some NCNs which have to have prioritised certain services. Yeah. So I just think if that would be okay, Anne, and it's possible, I think that would give us a bit more context. Thank you very much.
Thanks, Shelley. We can do that. Paul, have you got your hand up? Okay. Are there any further questions to Nick? If not, thank you very much. And, it's great to see the progress that is being made, despite the difficult circumstances. Can we go to 4 Gwent Regional Partnership Funding update, please, Nick? Gosh, you've got a lot to do today.
I know, it's the Primary Community Care Roadshow this afternoon.
It certainly is.
So this paper is an update on the position with regards to regional partnership and transformation funding, and bringing it here really to make board members aware of the potential changes and risk aspect as we move through this financial year. The Regional Partnership Board, which myself, Judith Teague and Anne and others sit on, has seen significant growth over the last few years, certainly the last 6-7 years, in terms of the amount of funding available for the portfolio of activity that sits within the auspices of the RPB, and this year has reached £36 million in terms of funding that is deployed. That funding model is due to end on the 31st of March 2022. It was delayed a year due to the pandemic, and we're now moving towards a 5-year partnership integration fund, which is due to be launched in the next couple of months, which will replace the existing ICF grant funds and transformation fund. And what I'm attempted to do through this paper is provide assurance and clarity to the Health Board on where we are with the arrangements and the oversight of that funding change as we move forward. You'll note on the second page of the report that the RPB through Welsh Government has very clear priority areas for integration identified for utilisation of the funding and the funding pots that come. So quite often we hear about the need to invest money in particular areas, but we are directed through the RPB to invest in the 4 areas outlined in proportionate terms for older people with complex need, including dementia, carers and young carers, children with complex needs, and people with learning disabilities. So we do need to ensure that we channel the monies that is invested through the ICF in particular into those 4 key priorities. And what we've established in the Gwent Regional Partnership Board is a structure where recommendations around the funding come through the local strategic partnership boards, which are detailed in the chart that is on page 2 or 3 of the report. And you can see we have a number of forum which discuss the funding and have allocated monies that's then authorised through the leadership group and the regional partnership board. The area of funding growth has been quite significant. As I said, it's gone from 3 million to 36.5 million over the particular time, and we've had to really put in a very robust governance structure to oversee that funding and the way in which the programmes have been established. And part of that was to establish a portfolio management office, which is led by Roxanne Green, who's part of my team, which has established governance and oversight of all of the monies and reports that into the RPB. The Programme Management Office has set out as well this year to review where we have spent the money and to set up a risk analysis and review for us as we move into the new arrangements for 22-23, and we'll come to that in a moment. But you'll see as well, in terms of the assessment in this paper, the allocations of money and where we have acted as a banker, there's the health board, deployed the £36 million that is available through both revenue and capital work streams, and also the transformation fund, which was a short-term 3-year fund to support integration and place-based care that we bid for a couple of years ago, and this year we'll receive just over £5 million worth of funds to support integration and development of place-based care. And what we've done in the paper is also highlight where we deploy this money on a divisional basis within the health board, so you can see the spread of risk, if you like, across the particular divisions. So there is a sort of quite wide split in terms of both the transformation and ICF monies across 3 or 4 of the divisions. So in particular, families and therapies, mental health and primary care and community services receive the vast majority of the money, and the health board is in receipt of £11.9 million of the £36 million in total. So we are in effect exposed to a third of the fund if all of the schemes were to stop at the end of this financial year. So collaboration is underway to look at how we manage this transitional year across Wales through the RPBs, and to develop a future funding model that reflects both the learning from the Integrated Care Fund and transformation, but also allows ministerial commitments in terms of that integration fund and the deployment of monies across both revenue and capital work streams. To support this, we've undertaken risk assessments across all of the partnership initiatives to determine the potential implications should funding not continue at the same level. And I think it's important to advise that we need to consider this, because the indications coming from Welsh Government is that they would expect around about 35% of the current funding streams or work to actually cease at the end of this year, and that the remaining sort of 2/3, whilst transitioning into the new fund, would then expect it to become part of our core service offer in 2 years' time as we move ahead. So it's quite a complex process that we're undertaking in terms of that risk assessment. There's obviously also implications for workforce. So we currently employ 432 people through our programmes, and the vast majority of those are now entitled to permanent employment rights. And again, we need to consider, if they are working in areas that are funded that are likely to stop at the end of 21-22, how we redeploy those staff into either other vacancies or other work streams that we've got and will continue as we move forward. And there has been discussion about whether or not, certainly in local authorities, they would seek to make some of those people redundant, which I think in the current workforce challenges that we've got locally would be a mistake, and we should be looking to ensure that we redeploy all of those staff who are if you like, made redundant because a scheme comes to an end, either into the health board or current vacancies within local authorities and partnerships. As I've said earlier, the funding supports a broad range of capacity across many of our core services as well, in particularly within health and social care community services. And we've delegated quite a lot of delivery to the third sector. It supports significant work in graduated care and step-down capacity, and also flow in the system through areas such as the community neuro rehab service, and also in terms of discharge coordination and flow in the acute and ELGH hospitals. So as we move through the next 6 months, I think it's important to understand the concept of the fact we will be transitioning into a new type of fund. The transformation fund in ICF will come to an end, and we need to use the opportunity as programs are stepped down to build system resilience and workforce resilience in those areas that we either redeploy staff or redeploy schemes and monies. And previously we've used monies from ICF and transformation to support a non-recurrent effort at winter. And in particular this winter, I think it's going to be really important that we can combine all of our effort, whether it be through the RPB, through local strategic partnerships and the health board and local authorities, into that effort to support patients and communities through what's likely to be a very challenging winter period as we transition into a new integrated fund in March, April of 22 next year. So I'm asking the board to note the range of investment currently supported in the health board in the region of £11 million, the risks associated with the cessation of this funding, and acknowledge that the fact that we are currently working through a risk assessment of that work and the way in which we transition into next year, and the constraints that then places on us in terms of delivery of service as we move into 22-23. Happy to take questions and appreciate it's quite a sort of complex story, but I think it was important to bring to the board's attention where we are with the regional funding, as it is quite a significant amount of resource, and also acknowledge where we are in terms of the development for next year.
Yeah, thank you, Nick, and it certainly is complex, and a fairly thoroughgoing evaluation of all these schemes is ongoing at the moment, so we do know what has and has not been achieved against the objectives put forward for the schemes, which will be important in decision making. So can I start with Paul, then Louise, then Emrys?
I'm just going to say, really, I wonder if there's a case required to look for continued funding. I mean, if we did, I don't know whether there's an equalities impact assessment going to be completed as part of the risk assessment. Look at the groups.
Yeah.
I was looking at the. That's wonderful, because looking at the list of groups there, I mean, I think it would be helpful if, at least for another year or two, that there could be continued funding to sort of, because with COVID and everything else, there's been obviously an impact, and whether there's a special case to be made for continued funding. That was just the plea I was going to put in for, because, I think, with the impact of COVID on this, there would have been delays with a lot of the work that possibly would have been undertaken, particularly with face-to-face and stuff, and just a thought really as to whether or not that could be considered. Thank you.
So I think, thanks, Paul. I think that was the approach that was taken probably a year ago, because a year ago it was due to end in in March this year, and it was extended for a further year. And I think, whilst I totally understand the point you make about the sort of the risk of continuity in terms of particular services, I think we've got to be clear that we are moving into the likelihood is the funding package will be similar in totality. What we've never been particularly good at is when an idea isn't working, is stopping doing something. And I think, we've got to be, we've got to get value for money out of the way in which we deploy this fund. It is a considerable amount of money, and if something isn't working, it has been given probably in most cases a really good shot over the last 3 or 4 years, and we should probably stop doing it. And absolutely be clear that those services that we see as core or integral to our service delivery and protection of the public are continued, and that we put our efforts behind those in terms of the continuity impact as we move forward. But absolutely, from an equality impact assessment, that will be done as part of the risk assessment. But I think we need to be clear that we do need to stop doing certain things, otherwise we'll never move ourselves on, if I'm honest.
I think you've explained it all. I think you make a very good point as well, that if there is a time when we need to review particular situations and thinking, well, that's working well, we need to develop it. That hasn't achieved what it has. Therefore, we look to not continue it. So, and I think you've raised the other issue, which is to do with staff and what was going to happen, because after, I think it's 2 years these days, the people get permanent rights with regard to their posts, etc. So I think in that sense are working. So I think you've raised that, you've mentioned that as well. So thanks for that, Nick. Much appreciated.
Thanks, Paul.
Louise?
Yeah, thank you, Nick. I welcome your comments about redeploying staff rather than looking at redundancy. So that's a good thing, and hopefully we'll be able to move on that and do something about it. I just want to know what are the risks to the other projects within the health board that we already commit to, not the ones that are attached to the NCN, the regional board stuff. Yeah, sorry. But stuff that we've already committed to within the health board itself, are they at risk in order to be moved aside for us to adapt some of these other projects that we might have to take on?
I don't think they are particularly, Louise. I think, we're in relative terms, if you look at the fact that we've got a third of the money is deployed in the health board, our element of risk is probably considerably lower than the local authorities. A lot of so if you take, for example, some of the service developments that we've delivered through graduated care, discharge coordination, flow, etc., I think we would seek to make those an integral part of our service model. And I can see Glyn on my screen, and I'll be coming cap in hand, I'm no doubt, to Glyn at some point for continuity funding. But I think it's fair to say we can make a good case for a lot of the health board deployed schemes that we would continue either through the new funding arrangements or through substantive monies that come to the health board in its budget settlement next year to continue with those. But as the same with everything, we need to make a case, we need to demonstrate value, and we need to demonstrate impact. And notwithstanding, we have significant vacancies across probably every area of the health board. We would be able to redeploy people into those vacancies, I'm quite sure, and wouldn't want to lose any staff. So I think that would be where we're at, Louise. I think it's, if the case is made and it's a good case, then I'm sure we would continue to do something.
Okay, thank you. That's very encouraging. Thank you, Nick.
Thanks, Louise. Emrys?
Thank you, Nick. Just a couple of comments. One, I suppose as a health board, it must be quite difficult being a banker vis-a-vis a commissioner. That's just one comment, I suppose, in respect to that, particularly when we're working across agencies. And then obviously picking up on your the criteria that you've been referring to, Nick. Obviously, what we've commissioned, the success of it, our evaluation and the impact of it, and how we prioritise going forward. What would you say, and obviously about the, when ideas aren't working, that we should terminate them. What would you say were some of the key lessons learned for us in respect to this, Nick, perhaps going forward, that we might be able to utilise again in the future?
Yeah, so I think in a lot of ways we do too many initiatives, Emrys. I think we do have a tendency to have initiative-itis, and actually focusing on some of the bigger, more impactful programs at pace and at scale, I think would have a far bigger benefit. I think there's something about we've got to learn that, we've got 5 local authorities and 1 health board. We need to start looking at a single set of standards and approach for things, where what we've allowed to happen is each individual local authority or NCN area has bid for monies and does a sort of variation on a theme instead of a clarity of purpose. So a good example of that is the way in which we've approached compassionate communities, and we launched that in 2 boroughs, and it was effective, and we sought to roll it out into Newport and other places. Yet they wanted to change the model to Newportify it, if you like. And actually, what we've got to get to is a single method of delivery and deployment for some big scale change that we all commit to, rather than 100 projects around pretty much the same objective.
Exactly.
Yeah, thank you, Nick.
But it's very
Thank
difficult,
you.
Emrys, as you'll appreciate,
Yes,
trying to
I
influence
agree.
partnership members, etc. in that.
Sure.
Yeah. And it's not easy.
No.
But it's worth pursuing. Tish and then James.
Thank you, Chair. Just coming back to Nick's comments about us being very good at setting things up and trying things out and then just continuing them. I think the new funding arrangements lend themselves to moving on from that. If you look at the structure of that, and I think possibly at some point if that could come to planning committee so that my colleagues can see that as well. Because the way that it's structured does focus the thinking on innovation and then on embedding and so on. So I think that would be helpful going into the future. I completely agree on the single approach and a fundamental approach. I think we need to, rather than trying out bits and pieces that we think are going to work, we need to reinvent our thinking and have a fundamental review of our collective approach as partners. And I think the urgency and the pressing nature of the situation that we're currently in will probably focus our thinking on that.
Yeah, I agree. Thank you.
I would agree, Tish, and I think the funding model that was potentially presented, I think at RPB last week, I understand that come the end of October we'll have clarity on that. So I think there'll be something that we'll be able to fulfil that ambition of sharing it with everybody at that point.
Thank you. James?
Thanks, Chair. It was just to reiterate the importance of what Tej and Nick have just been talking about, because it's one of the things that's really struck me since I've been in the health board. You know, the baseline that we should aim for is that we think as a health board and that our aim is equity of access for patients, irrespective of where they are in our health board, and that any variation that is applied should be because that variation meets patient need and isn't for meeting some other random noise in the system. And it, you know, a ridiculous microcosm I was dealing with yesterday is we were asking the very simple question of, if a patient with COPD deteriorates in their home, what service is available to help them stay in their home? And it's each borough sometimes has two systems even within the borough. So it's like trying to nail jelly to a wall. And it's not surprising that GPs don't access admission avoidance services because they're so complicated. Even with all the people in the room, they don't understand what the offer is. And you know, we ultimately do a disservice to our patients when we allow this to happen. So you know, we need to almost go back to the basics, and the basics is what is right for the patient, and how do we meet that as a health board, working in partnership with our local authority partners. So it goes across everywhere really. So I just want
that's a fundamental point, James, with which I think we all agree. Circumstances when these funds were set up did not always help the achievement of those aims, and I think that now that we are reassessing the schemes and re-evaluating them with the new resource regime coming into place, we should be able to endorse and reinforce that principle, which is fundamental, because it does worry everybody from the health board on the RPB that there could be growing inequalities because of the different styles of service. And you're right, people don't understand the differences, which is not helpful.
When you get down to the level of having to look on which side of a road someone's lives, you're doing something wrong.
Yes, exactly. Okay, thank you very much indeed. Thank you for that, Nick. And we'll have a further update anyway at the Strategy and Planning Committee. Thank you. Winter plan.
Me again.
Nick, you again.
So what we've done here, Chair, is we've brought a paper which really starts to describe our approach to winter resilience planning. We would normally bring a winter plan at either the September or November boards. We haven't received guidance yet from government in terms of winter plan or funding, etc. But we felt that considering the current pressure in the system and the position that ourselves and other health boards are in, it was important that we sought to assure the board that planning for winter and actually deployment of many of the winter plans is underway, and detail for you our approach, recognising that this is going to be, I think, a very, very challenging winter for many different reasons. We normally plan and deliver on a whole system approach, and we normally pick up the demands of respiratory illness, the onset of flu, but with the ongoing impact of COVID, as well as incorporating the sort of resilience and restart and recovery demands, we thought it was important to lay out as a whole system how we plan to approach winter for the coming year, with the aim really to bring a full winter plan to the November board for board sign-off and assurance. I think there will be an expectation from Welsh Government that we continue to plan on a regional level, and that any funding support for winter itself will probably come through the RPB as it has done in previous years. I'm aware that social care have had allocations of money to support resilience over the next few months, and I'm sure they'll want to share their plans with partners in the region and also contribute to part of the winter planning effort. I think it's important to stress, and this paper stresses, the current situation within health and care is extremely challenging, and it remains impacted by a very large number of factors, not least the ongoing COVID pandemic, but also the backlog of service demand within health and social care, and the anticipated increases in influenza and RSV over the coming 6 months present us with a real significant challenge. And what we've tried to do is detail some of that, if you like, the anticipated impacts in terms of both pressures, but also the workforce well-being and shortfalls that we're facing, some of the capacity and constraints within local authorities, which again we're currently experiencing, whether that be through ability to start packages of care or the fragility of the care home and residential care sector. We've obviously got significant challenges in terms of restart and recovery of services, which may jeopardise our plans to restart activities across elective care and cancer pathways, and the resilience of our services in the community, both in primary care and dentistry, as we mentioned earlier, are really quite challenging at this point in time. Obviously, in winter we expect some extreme weather, and we need to plan for that and the impact that has on our system, and also some of the knock-on effects of both the pandemic and Brexit in terms of things such as equipment shortage, driver shortages, and we're currently seeing with the blood bottle shortage and some aids and equipment that we're finding it difficult to source. So all in all, it adds up to a very, very challenging picture. And what I think we need to consider is our approach to meeting all of those challenges as we move through the next 6 months. So as in previous years, we'll be detailing a review of the system capacity and demand. We're waiting for the modelling for the current wave of the pandemic from Welsh Government, or we were when this paper was written, and we need to also pre-plan for our escalation of the release of bed capacity, as we've done in previous years, and the identification of periods of intense activity, which will require us to put up extra beds and extra capacity in the community. We will also be implementing the influenza plan as detailed in this paper, and also started this week the COVID vaccination booster programme and potentially the rollout for younger people. Based on all of that I've said so far, I think we'll need a very clear and coherent communication strategy and plan to inform the public and also our staff of the approach that we're taking. So we've identified the key winter risks as being as follows. The risk of a third and fourth wave of COVID and what that does to our system and its fragility, and the multiple threats that presents then with respiratory disease such as flu and RSV. Clearly that will put our critical care capacity under intense pressure, as it is normally in the winter period, but add in the additional impact of COVID, flu and RSV, we could find ourselves in a very stretched position. I think at the recent meetings with board members, I've highlighted the challenge that we've got with primary care capacity and GMS access, and we continue to see a reduction in activity due in part to availability of the workforce, but also the challenges we've got in meeting the demands of the public. We have a very high level of risk around the availability of additional staff, whether that be through the use of agency and bank or through our existing staffing resource. And the resilience of our workforce is going to be really crucial during this period. They've gone through a very, very challenging 2 years and face another challenge over the next 6 months. And we need to work on a number of areas to build that resilience and work with them to ensure that their well-being is maintained. We know that we've got fragility in the care home sector, and add in the fragility that we're now seeing in the domiciliary care sector. It adds up to a significant challenge for local authority providers. We've talked previously about the mental health impact of the pandemic and the unmet need and the surge, if you like, in the foundation level and tier 1 demand for mental health services. And we've also seen an exacerbation, an increase in acuity of those patients that are already known to us in both secondary and tertiary service delivery. So we plan to meet as a whole stakeholder group at the end of September to look through how we can plan and deliver together over the next 6 months. We will set out a modelling exercise for demand and capacity, and we will clearly need to meet the demands for capacity that throws up. But I think in terms of the scenarios that are likely in that, we will have to do certain things differently or make some difficult decisions should we require the capacity outlined in the model. So in terms of what are we going to do, the seasonal influenza vaccination programme is key. We've been successful in previous years in rolling this out through primary care services, and we will continue to roll that out through our primary care partners through the next few months. I think we're expecting it could be a difficult flu season because of the impact of the pandemic and people not having been exposed to flu over the last couple of years. I think there's also a concern as to whether or not the vaccination will be for the right strain and how we manage that as we move forward. It's based upon an assessment of the JCVI in terms of the vulnerable groups, and the suggested programme is laid out in the paper in terms of the groups that we would seek to vaccinate, from children under age 2 right the way through to frontline health and social care staff and those over the age of 50. And the programme, I think, is either got underway or will be getting underway in the next couple of weeks. In terms of meeting the needs of primary care patients and the demand for primary care and good access to services, I think I spoke with the Quality and Patient Safety Committee about the fact that we're currently seeing activity at 20% above pre-pandemic levels, and we are looking to invest circa £1.2 million worth of additional sessions into primary care to support primary care practitioners to offer extra sessions so we can meet that excess demand. We're also working with all of our primary care practices to ensure that they meet the basic level of access in terms of the 1 to 200 and the telephone line access that we talked about in that discussion at Quality and Patient Safety. We did a review on Monday of all 75 practices in Gwent with the primary care team to look at the sustainability issues and work through some risk assessments in terms of how we would respond should we find it difficult to maintain service in any of those practices. We're also looking at the graduated care model and how we can plan to deliver care closer to home, utilising our community care bed base and the CRTs through the winter. We've got enhanced care home support being put in through a rollout of our care home support teams that were rolled out in Torvine a couple of years ago. And we will be implementing the D2RA pathways wherever possible, utilising the care home beds for step down and also further resilience and support into our CRT and rapid response teams through the recruitment of additional MDT workforce, which we started this week. So we're seeking to build resilience really around primary and community care so that we can support patients staying at home or staying in their local communities to receive care and not having to advance through the system into secondary care and attend through WAST or through their self-presentation at the GUH. There's also considerable amount of work ongoing within the urgent care and secondary care system, looking at how we can model and maintain our baseline bed capacity of 1,500 and add in potentially a further 200 beds to the system through the winter period. They're looking at different pathways, whether it be through respiratory, chest pain, minor injuries and head injuries, and the implementation of assessment pathways and triage at front door models to ensure that we put people on the most appropriate pathways. And as James pointed out earlier, we need to be clear that our pathways are delivered across 5 boroughs, not just one particular area, and that we get a consistency of delivery. And the teams are working on how that can be delivered. There is also a number of pilots underway in terms of the ambulatory care pilot that's due to be launched at the Grange, and currently we're doing a test pilot. There's a look at an integrated front door model at Neville Hall to provide additional capacity for older and ambulatory patients really to avoid accessing the GUH. And there's a number of specialties, including care of the elderly, gastroenterology, etc., who are progressing with Consultant Connect so that we can link patients and GPs directly to consultants for advice before we convey patients into the system. As we've seen earlier today, there's a lot of work going on in terms of mental health and the additional demands that we've seen in mental health services over the last few months, and how we can build a range of community-based services and resources to support patients so that they don't access, whether it be primary care or secondary care services, but actually are dealt with at source. So as I've mentioned, we've introduced psychological wellbeing practitioners across all of our NCNs, and we've increased capacity within our primary care mental health team so that we can meet the demands of patients at both the foundation and tier 1 service. And we've seen today the great work of shared lives, and we are advancing the work in terms of sanctuary provision, support house and peer mentors in our crisis services so that we are in a position to be able to respond to patients who do present in crisis. So I think it's fair to say, Chair, right across the board of services, there's a huge effort going on to build resilience and plans for the winter period, and we will bring those together as a full plan for the November board. But I think we also must make reference to workforce and the challenge that we've got with workforce, and the excellent work that's been done in terms of workforce wellbeing and the wellbeing surveys and engagement really with the workforce over the last 12 months, and the need for us to build on that through the winter period, recognising that our staff are not robots, and their resilience has really been tested over the last couple of years, and the work that Sarah and the team are leading is going to be key in how we manage to get through the winter. Yeah. And also then the public communication messaging during winter is a key part of how we plan. And the strategy for winter will be developed and agreed with partners, but it's got to be around a preparedness campaign that takes account of COVID, but also builds on the requirements to ensure patients and the public know where to access care. And I think that's one of the key elements of that. And we talked about that with dentistry earlier, and informing the public effectively of where best to access services and choosing well, using the branding we've used previously will be really key if we're to maintain resilience. So that's a skip through the paper as laid out, Chair, and as I said, It's just really to note the approach we're taking for winter this year and be assured that the planning and operational teams are advanced in the planning, and that we will bring back a full winter plan to the next board session. Thank you.
Thank you very much, Nick. That was a very comprehensive, well thought through plan of action, and we look forward to seeing the final winter plan, because I know you will have evaluated what did and did not work last time and incorporated that into it. Paul?
Just some issues that seem to have come up in the media, which may not be altogether relevant currently for Gwent, but maybe in the longer term. And the availability, if I can list them, Nick, and perhaps you can answer them. One is the availability of flu vaccinations, whether those are going to be available for all. That's the first thing. Secondly, whether any military vehicles are going to be used at all to assist with ambulances, which has been suggested in other health boards. Thirdly, whether we've got the opportunity still for blood testing, in other words, for that to be available at GPs. And fourthly, something which is quite close to home is the schools being closed with COVID, and an example being in Brecon, which is not too far from where we are. So those are the sort of issues that I think probably patients and individuals on the ground will be thinking, okay, so what's happening about each of those? So are you able to update us on them?
So I will also ask a couple of my colleagues to update, but as far as I'm aware, there has been a request from the Welsh Ambulance Service for military assistance. I'm not quite sure how that's going to be deployed, but I think we've seen that in Scotland. It's been deployed in Scotland and Northern Ireland, and I think I'm certainly aware that Welsh Ambulance have requested that support. Yeah. In terms of school closures, I read something yesterday about impact in absence at school at the moment is relatively low. I think it was about 1.9% for the first 2 weeks back to school. So I've not picked up any local issues with school closures, but I'm going to defer to my public health colleague, who will probably have better information, but also be able to update on the flu vaccine. And blood test bottles, again, I'm going to defer to one of my colleagues, the medical director, who's probably got more up-to-date information than I have. So sorry to pass those off, Paul. But
So Sarah, can you pick it up, please?
Yeah, on the outbreaks of COVID in schools, they're quite local. So I think the issue is, from a staffing point of view, is that while it might not be a big number, it can hit teams who may live and work in the same area, in terms of a number of parents being affected because their children test positive and they need to isolate at home at the same time. So, and it's nigh on impossible to predict as and when that might happen. So I think there's an operational issue that we are experiencing ourselves in terms of school outbreaks having knock-on effects to staffing constraints in particular areas at any one time. In terms of the controlling the spread of COVID in schools, I'm actually meeting with directors of education in Gwent this week, because the guidance is one of those COVID experiences where the guidance in theory is right, but in the operational detail proves to, the devil is in the detail. So there are practical issues with how that guidance has been put into operation in schools, and it's creating difficulties for schools. So I'm meeting with directors of education, and then there is a process whereby the Gwent incident management team for COVID formally sends in an SVAR to Welsh Government every week. That is our route for alerting government to the issues that we may be experiencing, and the meeting with directors of education will inform our comments back to government. So that's where we are with schools. I think we're still in an element of teething issues as we move to a new way of controlling COVID at the start of the academic year.
Thank you.
James, availability, sorry.
Flu vaccine, there's I'm pleased to be able to tell the board that in terms of our health board supply for staff, it has apparently arrived.
Oh, good.
I hesitate to say this out loud, given previous years, but as things stand, the flu supply issues are not a constraint. You'll have picked up the issue around delivery of a particular vaccine for the over 65 population being delayed due to the shortage of drivers, but the GP flu program has just around the new delivery date.
And James, and blood bottles?
So the blood bottle situation continues to be managed within the health board using a sort of gold command incident type management approach. And we had just before I went on holiday, which was a week ago, we'd achieved a 6% drop in use of blood bottles within secondary care, but a 50% drop within primary care. So we were keeping the use of blood bottles within the sort of parameters that we need to respond to the shortage of bottles. We found out yesterday that we've just had a new source of supply come online for the purple top tubes, which has pushed back a crisis, but it continues to be an area that is needing to be actively managed. We have been alerted by the medical examiner's office that there have been cases of patients who have died as a result of inadequate management of potassium levels. And for non-medics here, potassium levels can go up as a side effect of certain medications. And if your potassium level goes high enough, then your heart stops. So it is really quite a key patient safety issue. When I received that advisory for the medical examiner's service, I did go back to our local mortality review group and was reassured that none of those cases have been in our health board. So the message that we are continuing to put out is that where blood tests are essential, they should still be done, but the need for doing blood tests should be driven by senior clinical decision makers. And the advice now is, as it was at the beginning, that the blood tests that we shouldn't be doing are associated with reducing routine monitoring and inappropriate repeat measurement of certain value, certain things such as thyroid function. But safety, as always, comes first, and we are not in a situation where we are asking people to practice in a way that is unsafe. I hope, does that answer your question, Paul? So.
Thank you, James. Thank you, Paul. Any further questions? If not, can we note this report and the comprehensive nature of the actions that are being taken at the moment? Thank you.
Thanks.
Could we move on to the risk management strategy, please?
Yes, Chair. This is for me. This is a risk management strategy to be endorsed by the board. If the board can cast their minds back, we endorsed an approach in March this year, and this strategy takes that approach a step further forward into embedding the management of risk across the health board. The strategy continues with the approach of focusing on outcomes and objectives to achieve the outcomes, alignment with our key strategic and processes such as planning and performance, with developing further the reporting mechanisms and the risk controls around what we class as the 4 T's, terminate, transfer, tolerate or treat. We will be looking at developing the risk appetite this year as well to help with those control mechanisms, and to provide the level of scrutiny and escalation routes through the operational local processes and the board committee structures. We'll be looking at developing a community of practice, and that will include a variety of training methods for staff, management and the board itself. The strategy will be reviewed as per normal every 3 years, but we believe that this is a good strategy to take us forward to the next steps.
Thank you. Are there any questions to Richard? We have seen this, the development of this strategy. over the months. So we're happy to adopt it for the moment.
Yeah.
Shelley?
Sorry, Chair, I was just going to say we did receive this at the Audit Committee a few weeks ago, and we were happy that it's going in the right direction. It is a development area, though. That's just to be confirmed. Thank you.
Thank you, Shelley. That's helpful. Okay, we endorse this and we will watch an advancement. The strategic risk report.
Yeah, this follows on with the approach and linked to the risk management strategy, and it provides the board with assurance that the risks are being managed in line with the agreed approach. I think it's mindful to note that all the risk profiles here are fairly dynamic, and that we are developing them, and they are likely to change during the year. And throughout the day, I think we've heard of threats that are emerging, and which will then be looked at as part of the risk management process. The profiles here are detailed as the appendices, and obviously any specific questions about those, I would defer to my colleagues on that. But in terms of the actual report itself, we're showing 12 risks of a score of 15 or higher, and they normally come to the board. We've shown one which has reduced its likelihood, so we've reduced that score down, and the PQSC has agreed that, and that's for the board in terms of endorsements. But we're also proposing a change to one of the risk descriptions, which is around CRR 030, and that's in the paper, where we are looking at the sort of COVID restrictions, and I think we've already discussed some of those things as well, and we're looking at safeguarding of incidents. And that's changed, so to provide, I believe, a more inclusive risk and a more of a descriptive risk about what we are actually looking at in terms of contact with the public and NHS services. And the board is just asked to note the report for assurance, and note as well that the Audit, Finance and Risk Committee will be having a mid-year report at its next meeting, which will look at all of the risks.
Thank you, Richard. That's very helpful. Paul?
Can I just say, I think the format is so much better, and I like it. But what I particularly liked and wanted to sort of pass on is the action plan. Underneath each of the risks, there's an action plan with dates, etc. And I think this is incredibly helpful, because then we can monitor the progress of these risks, and they can be updated. I was going to ask Shelley, as chair of the audit committee, I mean, this model looks, I know it's an ongoing conversation, but with regards to the four types of risk, which the treat, tolerate, and transfer and terminate, that seems to be quite a good model as well. And with the updates that we're getting with regards to the action plan, that does seem to be a very good model for us to have as a board. So well done for getting all that together.
Thank you, Paul. Are there any further questions? Well, thank you very much for all the hard work that has gone into producing this report in its current format, because I know we have been pursuing an improvement in the reporting mechanism for some time, and this really does seem to be far more dynamic and understandable than previous versions. So thank you very much for that. Might we go on to the finance report, please, Glyn?
Thank you, Chair. Hopefully you can hear and see me.
We can this time, yes.
Wonderful, thank you. So you have the finance report here, which reported the position to the end of July, or month 4. Since that time, we've reported the position for month 5 and to the end of August, which is essentially reporting continued position of break-even, with a forecast of break-even on both our revenue and capital budgets. As I mentioned before, when we were talking about the Q3 budget setting for this year, the forecast very much assumes that the funding that NHS Wales has secured this year will be allocated out in line with our financial plan that we agreed earlier this year. So the forecast is very much based on those assumptions. I think really our focus, subject to the detail being confirmed at the end of September, will be around allocating that funding out, allowing budget holders to focus on delivering their plans for this year, but then also allowing us to spend more time on reviewing the underlying financial position. And again, the report sets out the underlying financial deficit that we currently face as a health board, which is hopefully not an issue for us in this current year, but is an issue that we need to address over the next few months as we go into next year. And I think it will be really important that as we start to look at our priorities for next year and we develop our integrated medium-term plan, our 3-year plan for next year and beyond, that we build into that some of the savings and efficiency assumptions that we need in order to address that underlying financial position. So it is very much about taking that integrated approach. And I think Shelley mentioned before the importance of looking at some of the transformational work programs that we've got and how we can make sure that we're making better use of resources whilst at the same time improving outcomes for our patients. So that was really all I wanted to cover on the finance report, because I think we've already covered some of the issues earlier on. So I'm really just asking the board to note the position which has continued to the end of August, note the forecast, the balance forecast against both our revenue and capital financial budgets. There are clearly a number of risks and opportunities that we will need to manage as we go through the rest of the year, and in some ways we've described some of those in some of the other agenda items like the winter plan. And then just to note the performance on the public sector payment compliance and cash. So happy to pause there and take any questions. Thank you.
Thank you very much, Glyn. Shelley?
Just a quick comment to say thank you to Glyn for the report again, which is very comprehensive. And we obviously have discussed a lot of this at the audit committee, but I just wanted to emphasise that with the transformation of services and potential efficiencies coming out of those, which will improve outcomes, etc. One of the things we have asked at the committee is that when we get those presentations, that they focus on those areas that are directly relating to those two issues that I've mentioned, rather than, if you like, a whole approach to how the transformation, which obviously should come to a different place at the board. So I'm hoping that as next few months go forward, we will get more of a handle on where we're going with that. So I just wanted to make that point. But welcome the report, and I'm confident that the finances are being very well managed, and hopefully we will meet the requirements that we need to at the end of the year. So thank you.
Well, thank you very much indeed, Shelley, for that. Confirmation of the confidence that the audit committee has in the way in which the finances are being managed in very difficult circumstances. And I entirely endorse your approach in terms of changes in the way in which programmes of care can be delivered and what the audit committee actually needs to know, rather than everything I would think that's absolutely right. So are there any, any other comments? No, thank you very much indeed, Glyn. We know it's a really tricky job to try and manage within such uncertain circumstances, but we have every confidence in you and your team and the executives in overseeing this effectively. And on to your performance report.
Okay, thank you. And again, I'll keep this fairly brief because I think the report is fairly comprehensive in terms of the key performance indicators. Most of them in the report are reported to the end of July. And again, I think it's a continuation of some of the discussion that we've had earlier during the board, that during the last few months, the health board and locally, we've seen a significant increase in emergency and urgent care demand. We've seen rising COVID infection rates, which has also impacted on things like increasing staff absence. And I think this is very much reflected in the narrative behind some of the performance indicators. So not just the performance indicators around access to A&E and our EDs, for instance, but also some of the other services where we're looking at timely access to them. And if I can perhaps just share a sort of a brief insight with you as a board around some of the ED and minor injury attendances. If you look at the period of June and July of this year, 2021, and you look at the number of attendances to our emergency departments and MIUs, and then you do a similar comparison to June and July of 2019, which was the year before the pandemic, we've seen a significant increase in the number of attendances to both our EDs and minor injuries units. So something like an increase of over 2,100 attendances during that 2-month period. So it equates to something like a 7% increase. So that is significant when you think about all of the other pressures that the system is dealing with when we talk about increasing staff absence and making sure that we still safely deliver those services. I thought it was worth referencing that because when you actually look at things like 4-hour performance, so that is one of the critical sort of time indicators in terms of access to care in our EDs. The 4-hour performance has only dropped very slightly from June and July 2019 to June and July of this year. So our 4-hour performance sort of 2 years ago during that period was around about 76.4% and 73.4% for those 2 months. And what we're seeing this year is only a slight reduction in the 4-hour performance, and yet we're experiencing significant demand through our EDs, and we're contending with all of those other pressures around having staff available and so on. So I think it is really important that we understand the context within which some of our services are operating, and I thought it was worth just sharing that bit of insight with the board because I think it demonstrates how resilient some of our staff and services have been during the last few months. I know that Nick talked in quite some detail about the winter plans, and clearly they will be really key in making sure that we continue to provide good access to a range of our services as we go through the rest of the year. I wasn't going to say a lot more around the performance report. I know that I have had one question from Tej around the extent to which patients waiting for surgery have had to cancel that surgery because they've tested positive for COVID, and similar question around disruption to our planned diagnostics. If I can, it's quite a detailed question that we need to go away and look at in some detail. So rather than try and attempt to respond to it today, if I can do that separately and come back, and I'm more than happy that we report that back through the board as well. What you'll see in the report is that we do look at short notice cancellations, and this is probably a small subset of those cancellations, so it probably requires a more detailed review of that. And I think during the period of sort of June through to recent months, we've seen a reasonable fluctuation in cancellations, but it's for a number of reasons. So some of those may be related to us as a health board having to cancel because of significant emergency pressures, but some of it will also be related to medical reasons and reasons that are perhaps personal to the patient. So I will come back to you separately on that, Tej, if that's okay. That was really all I wanted to sort of cover on the performance report. So again, happy to take any questions.
Thank you, Glenn. Steve?
Thank you, Glenn. That would be helpful. I think what I was particularly getting at, rather than really stark numbers, was the disruption to the flow through the system to to that point. So clearly we plan for surgery, plan for, you know, diagnostic tests to be carried out and so on. So it's just this disruption to that in the light of increasing numbers in the community. So it was a feel for that. Thank you.
Yeah.
Thank you. Are there any further questions on the performance report?
No, well done.
Thank you. The executive team report, Judith.
Thank you. I've just sending another response to Shelley, but I'll do that after I finish this. Thank you. So thanks. Here's the exec team report. I will do light touch on this if that's okay in view of the time. Hopefully it covers it does cover a broad range of issues and things that have happened since our last board meeting. Just a few things to draw to your attention. Clearly we had the opening ceremony for the Grange, a lovely event. Thanks to everybody who joined us that day. There's a short update there on COVID system pressures, but clearly Glyn has also mentioned some of that as part of his highlight report on performance as well. You'll note on page 2 that one of our consultants has published a guide for junior doctors on how to survive, which has been promoted to all our junior doctors as part of our induction programme. I haven't read it myself yet, but I do plan to, but just thought I'd highlight that publication. And then last week, just as we were sending the board papers out, we had confirmation that our Corporate Health Standard Platinum Award had been reallocated to the health board. So you'll know we updated on the Gold Award quite recently, but now we've been revalidated for Platinum as well. Just a few other points of interest. Some particularly good work done by the Mental Health and Learning Disabilities team, the OT, Clinical Practice and Education OT, Sarah Moorcroft, about how we've adapted placements during COVID. You'll see that 2 of our colleagues were nominated for the Ethnic Minority Women's Achievement Association Awards, and I know Priya Fernando was successful. I haven't heard about Manwik Kaur, but I have seen quite a lot of publicity about Priya's award. And also then just to follow up on some additional funding that we have received from Welsh Government, a considerable amount of money actually, to make sure that we can provide emotional well-being and mental health support to children and young people through our schools, based on some work that had been done in Blaenau Gwent and Torfaen. So based on a successful model, £778,000 been allocated to the health board to work with schools on that, and a really important work. And then finally, the very final thing to draw your attention to on all things COVID is that you'll remember the critical programme, Coronavirus in Intensive Care, that was filmed with body cams from our consultants in the ITU at the Royal Gwent Hospital. Just to say that has been nominated for a Wales BAFTA award, so we're very excited about that, and hopefully we'll hear from that about that very soon. Just like touch, Chair, there's loads of good other things in there as well, but just a couple of things just to mention, so thank you.
Thank you very much, Judith. Has anybody got any comments or questions? Huge amount of work going on, absolutely huge, vast scope, and really quite enthusing. Paul?
Just to say, I think, you know, we've all been made aware of the significant demands and system pressure and the staff support, etc. And I think just to say to you, Judith, huge thanks to you and to your team and all the staff within the within the system supporting health and social care at this very difficult time, and supporting families and patients. I mean, I think it's a very difficult time, but I think it's opportune for us at a public board meeting to recognise all the significant work that's being developed as we speak. Thank you.
Thank you, Paul. I know the executive team and everybody else will appreciate that as well, so thank you.
Yeah. Thank you. Any further comments? No? Can we move on to the key matters from committees? We have 3 and WISC. Anything from audit?
And I'd just like to just draw everyone's attention to the key risks and issues. The risk in terms of the commissioning the social care beds in the context of the financial position, because obviously that is open-ended, and I assume that is now forming part of our overall strategic risk in terms of finances. And the other one, which is linked, is the underlying financial deficit, which obviously we're looking now at the longer term view, which obviously I think is the only way we can try and tackle that. Thank you.
Thank you. Any questions to Shelley? No. Patient safety, Emrys?
Nothing specific to me from the report. The only thing I would add, though, Anne, is that for our next meeting, we are just reviewing and assuring ourselves of the controls between the committee, the operational group and the divisions.
Oh, good. Thank you. Questions to Emrys? No? Mental Health Act Monitoring Committee? Emrys?
Yeah, sorry, just the only one thing I would just add to that is that our reporting of the Mental Health Act is excellent in the sense that, sorry, I'll use the term informed in the sense that it helps us we get a wider view. We don't just looking at trends, we also look at some of the implications of those trends. So it's a better way of reporting at the Mental Health Act Committee. The only point I would raise here is that we are still developing or finalising our Section 117 aftercare plan. And when I say that, that's part of the Mental Health Act, but it has to be agreed and worked through with all 5 local authorities.
Yeah, absolutely. Thank you. Any questions to Emrys on that? No. WISC? Judith?
Nothing to add, Anne.
Right. I noticed that major trauma is mentioned in the WISC report. Do we know when we're going to have the evaluation of the effectiveness of the new system?
They said that they would do their formal evaluation after it had been in operation for 12 months, right, which will be coming up shortly. So it is underway, although at the last meeting we had a very comprehensive assessment of what had happened to date, both in terms of the operation of the network, flows of patients, etc. So yeah, the report we had last time was very comprehensive, although it wasn't the formal evaluation.
Oh, well, that's good. That's good. Anything further on this report? Any other business? If not, the next meeting will be on the 24th of November. We will have 10 minutes pause before we start our confidential agenda. Thank you.